Started. Good, right. Are we ready? And action. Hi, good morning, everybody. A really, really warm welcome to Birmingham. My name is Mark Radford. I'm the Director of Nursing Improvement at NHSI. I lead the programme and work on behalf of the Executive Director of Nursing, Ruth May, in terms of the workforce priorities and portfolio across NHS Improvement. So it's great to invite colleagues here today in Birmingham. I know the room layout is kind of odd, but it does work. I've been here before. But the main thing is we've wanted to put on a programme today to really kind of and identify. Before I go into that, there's obviously a number of sort of normal housekeeping rules apply in relation to here at the Jury's Inn. We don't have a fire alarm plan for today. You will obviously see the green running person signs at the back of the auditorium. If there is an alarm, we'll make way downstairs. We go through the through the lift, down through the stairs, and then there's a muster point out on the front of the hotel. We obviously do have refreshments available through that. Please help yourself. I mean, try not to distract some of the speakers, but if you did want to kind of quickly grab a coffee, but we do have a number of opportunities and breaks during the day. One of the things about these kind of events is it's really important to engage with other colleagues from other parts of the system, and also to kind of ask questions of the panelists and also the contributors today. We've been able to put a number of presentations on today where colleagues are going to be talking about some of the nitty-gritty challenges of running some of our provider organisations. So we will be obviously filming today, because what we wanted to do is kind of live stream this out to colleagues who have been unable to attend the event today. One way we're trying to reduce costs, and utilisation of the digital platforms are one way of doing that. One of our colleagues today will be presenting some fairly challenging own personal experiences of being a leader and executive within a challenged organisation. So we won't be filming that, because we want to create a safe space for them to be able to share their kind of experiences and challenges with you today. So it is a really good lineup in terms of people and colleagues who are going to be talking around their kind of experiences in terms of delivering change and improving outcomes in relation to their organisations. Obviously, all of the speaker notes and presentations will be available later on after the conference today for you to be able to get access to those if there are any questions. We'll obviously do have a number of my team here today in terms of the workforce improvement team as part of NHSI. Those of you who are here, would you put your hand up, please? Tony, yeah, that's you guys down there in the corner. Please, if there are any issues today, do not hesitate to either contact myself or a member of the team, either about the nature and the content of what we'll be discussing today, but also anything in relation to any workforce improvement that we're able to kind of support you with, and also importantly, any issues that arise out of being within this venue. Obviously, we do have refreshments up here. Lunch will be served downstairs in the main restaurant. It's only kind of one flight down, but kind of get you away from the conference centre for a little bit to engage and have a conversation and chat with each other as well. And also room temperature. We never get it right. I don't think I've been to a conference yet. So if I start to see everybody still wearing their coats, it might be too cold. So I will try and do that. If it's a real problem and really affecting your kind of focus today, then please don't hesitate to speak to me, and we'll try and resolve that as best we can, but we can never kind of get it perfect at all. So before we get started, I just kind of wanted to frame today a little bit before my colleague Emma McKay comes and describes some of the kind of rationale behind why we're here. We'll kind of focus on some of the issues and challenges. Workforce is probably the number one risk that all of us, whether we're part of the system or whether we're actually leading organisations, that we face day in, day out. And whilst there are incumbent on us to try and deliver effective workforce solutions within our organisation, that is extremely difficult to get right. And the kind of process that we went through in terms of developing workforce safeguards came out as a number of conversations we'd had with the provider sector over the last 18 months or so, and Emma is going to go into that in a little bit more detail. So today is really the sort of culmination, really, of the launch of the policy document that we put out a number of months ago. We deliberately timed this to, again, give people a chance to be able to read and assimilate what we identified as terms of some of the recommendations within that sort of program, but also then to put on an event like this where we could get senior leaders into a room to really start to explore and understand some of the implications for that kind of boards and also for operational delivery in terms of organisations, but more importantly in terms of kind of from a collegiate sense, how do we deal with kind of some of the issues and challenges we have in relation to the workforce space. So I'd just like to say, thank you very much for your time. I really do appreciate, for many of you, Monday is an extremely busy day. I also appreciate the distances that colleagues have come. The first person who's come up the earliest so far is 4:15. They got up this morning to come to this event today. So I'll be holding a little sweepstake a little bit later if anybody can kind of beat that. Apparently, Emma's, you've said that there's a bottle of champagne in it. Is that right? No. It might remind me, Emma, that wins it. So again, I really do appreciate your time and commitment today in terms of this really important agenda. Your feedback is really important. We'll have an opportunity to do that throughout the day, but also a kind of formalised feedback. Again, it's really helpful for us in terms of getting these events designed, created, and also delivered to ensure that they're absolutely making sure that they deliver for you as kind of leaders within the system. So without kind of further ado, I'll hand over to my colleague Emma. Emma is one of the improvement team who work within NHS Improvement, is one of our senior clinical advisors, has extensive clinical and kind of operational experience, and will give us kind of an overview as to kind of how we got here today in terms of the policy and the launch. So warm welcome to Emma. Thank you very much.
Good morning. Thank you, Mark. So, yes, my name's Emma Mackay. I'm currently working with NHSI. I guess I would like to start with saying that I had the great pleasure of working on this document. Now, I'm not saying that because my boss is sat in the corner. It's a genuine pleasure. I'm a director of nursing. I have been a director of nursing in a large acute organisation for many years. So I know the implications of new guidance landing on your desk. Particularly as we draw into the winter. So I think the opportunity that I had to actually influence and shape this document in order that its practical and sort of usability was able to be implemented, hopefully without too much stress and strain for some of my colleagues that work within the NHS organisations. So I guess starting off really, safe staffing, so what? Scrutiny over safe staffing is ever evolving. I guess we would all continue to believe that it is a line of continual improvement. We keep having new guidance that comes out because that's how we learn. We've learned from best practice, and we also sadly learn when things go wrong. Safer staffing really came under the spotlight, I suppose we would probably all agree, after the mid-staff's failings emerged. Back in 2012-13, when Francis then first highlighted safer staffing and links with quality and safety in his report. And throughout the past few years, we've seen more and more guidance come in, more and more expectation relating to that and understanding of what safer staffing looks like. We've had mandated reporting, we've had more transparency around it for us, for our public, for our patients. But again, we keep introducing more and more guidance again as we learn, really. So we started off with Francis having one recommendation linking staffing and skill mix to quality of care, right down to today, where we've got legislation, laws being introduced around safer staffing in Wales and Scotland. So I guess the big killer question is, why on earth do we need more guidance, you would ask? And I don't blame you. And that's partly my first response when we were looking at this. Well, we still have issues. Of course we do. Staffing continues to be a contentious topic for the NHS. And I think we would all agree that we're proud of the care and services that the NHS does deliver. And certainly, I'm sure every single one of you is extraordinarily proud of your staff that continue to deliver the care that they do under the circumstances that sometimes they have to deliver that. We know that there have been gaps identified. I've already said that. The more we learn, the more we realise, the more we need to learn. we need more focus and more support for organisations around workforce design and, of course, deployment of staff as well. When we're challenged with funding, we're challenged with supply issues, retention, recruitment of staff, and, of course, all of that leads to morale, and then the consequences are potential patient safety issues. We're approaching another difficult winter. Let's not kid ourselves that it's going to be easier. Things get tougher and tougher. And of course, scrutiny under staffing will continue to be put under the spotlight. There's no question there's a vast body of evidence linking staffing levels and skill mixes to quality and safety of the care that we deliver to our patients. So of course, we need to continue to learn more about that. We're slightly ahead with nursing. We've done more work on that, but of course there are other staff groups involved with delivering care to our patients. And now we've got the Royal College of Nursing actually driving for legislation in the UK around safer staffing laws. So over the past 12 months, I think in particular, but actually since 2012-13, when we started to really have to focus and start to report on safer staffing, we've made a lot of progress. Trusts have made an awful lot of progress. And we've seen that in various places with CQC and NHSI, and again, myself as a Don in a big trust. But what we are still struggling with, I guess, is some consistency in how we report and monitor, manage, review, and set staffing workforce plans. So design, implementation, and governance and reporting particularly were issues that we can see a huge variation with across the country. So unfortunately, or fortunately, depends how you look at it, we need to do more work. And that's we, all of us. That's the regulators and provider trusts. And guidance and support was felt to be needed. So our developing safeguards document was born. And it's taken, I would say, 18 months from thought to actually now, here we are today. It was actually developed with system leaders, so it's been well circulated and consulted upon to make sure that we try and support organisations in delivering best practice consistently. So that's really I suppose, concentrating on workforce planning, deployment of staff using evidence-based tools where possible, governance considerations, specifically around redesigning roles and, of course, how we report on staffing, and also the ever-challenging and ever more common responding to unplanned workforce challenges that we all have experienced, and if we haven't yet, we will do for sure at some point, where we have to make some difficult decisions. This document builds on the work that NHSI particularly have done to date, specifically around some sector-specific resource improvement guides that I hope you've all had sight of at some point. I know you're busy, I know there's a lot of information out there, but these are worth having a look at. They are specific, as I said, in certain areas where they offer recommendations and guidance around staffing for those areas. And that's not just the acute, that's also in the community trusts as well. We've developed a workforce planning tool that's, again, helpful in making your strategy and making sure that you plan your workforce, not just the day-to-day business as usual risk management, but the longer-term planning that obviously we need to be thinking about. And then very recently, we've had the development, which we're very pleased about in NHSI, of a Nurse Safer Staffing Fellows programme, which is going to be an academic programme to support education, really, and support around how you evaluate and manage safer staffing. And that's in conjunction with the Shelford Group, which hopefully all of you are familiar with. So some of the key messages in the document. Really, not much of it's new. Hopefully you've realised that if you have had a chance to be able to look at it. It's actually a collation of all of some of the, most of the existing guidance that's already in the system, but that we're not that familiar with or not that confident in using. So primarily it's about the NQB's 2016 guidance, looking at right staff, right skills, right place and time, and essentially looking at a triangulated approach to assessment and reviewing of staffing. And we, again, historically have focused on nursing, and that's using evidence-based tools. We know that we need to do more work, and more work is being done with making sure that we have more guidance, really, and evidence-based tools relating to other clinical workforces, such as doctors, AHPs, and other support care staff that deliver care to our patients. The NQB talks about also using professional judgment in support of its staffing reviews, which of course we do all the time, and outcomes, which again is something that all of us would be very familiar with, but sure they're appropriate in order that we can determine. The framework also provides some new recommendations, and that's specifically around reporting and governance. And Lorna, my colleague, will be talking to you in depth about that. And that's important information that I think you'll find extremely useful and very practical to understanding what you do when you leave here today, hopefully take back to your organisations. As I've said already, this is not about just nursing anymore. We realise that it's much more broad. It's every staff group that has any involvement really with care delivered to our patients, and in various settings as well, not of course just in hospitals. Another big focus, I guess, with this document was a stronger board engagement, and I think that it's updated annually and signed off by the CEO and the exec lead, not just the Director of Nursing, which is historically what's often happened. So, regulation. This is our first real step here in the UK towards regulating some staffing. And who knows, I think it would be highly likely, not sure when it would happen, but legislation will be introduced in the UK. We're running behind Wales and, of course, Scotland probably now as well. So we are asking, NHSI are asking for annual regulatory reporting from April 2019. So that gives us a few months to start to think about what needs to be done in the organisations, and hopefully today will be the platform to springboard you into making sure that you are really clear on that. We thought long and hard about how we do regulate staffing. It's exceedingly complicated and complex, and not just one or two metrics or bits of data will help us to determine what's safe in your organisations, for yourselves or for us, as we know. And we wanted desperately to minimise more regulatory burden. So what we decided was to assess trust compliance using information that's already collected in your single oversight framework, the SOF. And also we've added in a specific workforce statement in the annual governance statement, again, which will give us some prediction of where trusts are in line with some of these, well, these recommendations within the policy. And of course, when we give recommendations for trusts and organisations to adhere to, if they can't or they're struggling, we would be here to offer support. And again, that's in line with the SOF, depending on what elements the organisations have problems with, depends on the type of support that we can offer. But it will be available, and that's either by national teams, so our teams, or the all regional teams who you probably have more contact with going forward. So that's a really high level oversight of the document, where it sort of came from. And then there'll be some more detailed discussions going through the day about actually how you practically implement it and make sure that you're doing what is required for your organisation, and at least understand where your organisation stands in relationship to some of those recommendations. And that's it. Okay. I don't know who handing over to Matt. Right.
Appreciate that.
No problem. Thank you.
Oh, have you nicked the clicker?
Oh, sorry. Beg your pardon.
It's like doctors and pens, that is, isn't it? Clickers and things. So, thank you. Really appreciate kind of giving a kind of overview of describing, you know, some of the particular challenges of where kind of regulatory development comes from in terms of policy support to individual providers. The programme of work in terms of engagement, we met with a number of clinical and HRD leaders over the last months in relation to workshops, as well as also kind of engagement sessions, to really kind of explore the nature of that. And very kind, a number of people have been able to kind of support us in terms of framing this correctly, particularly in terms of making sure that the regulatory oversight is provided in a real world sense that actually does not necessarily add to the burden, but actually kind of does a couple of things, which is A, shine a light onto current practice, but also more importantly kind of expose the quantum of the challenges of the risks. The next bit, the document in practice, is kind of from my own kind of personal experience of being a provider chief nurse, but also kind of now working the last 18 months or so, working within an arm's length body, looking at some of the wider kind of system-based issues. And I think Emma's rightly highlighted a number of challenges, which is whilst we've got a great deal of already existing supportive policy and advice in relation to the challenges associated with workforce, the issues are predominantly around the consistency of its application across the system. And colleagues from CQC have often highlighted that despite this, we still find a number of issues and challenges within provider organisations where existing policy or practice or best evidence is not necessarily implemented in the workforce space. That leads to a number of known risks, as well as also unintended consequences in terms of the risk profile for individual organisations. So this kind of next session is really kind of trying to explore some of those issues and challenges, but looking more broadly at the kind of wider workforce context, but also in terms of what this document does in terms of shape the board's behaviour in relation to understanding risk, in terms of mitigating risk, and also importantly kind of developing strategies to deliver workforce improvements. But I suppose that the first thing to kind of describe to you is some of the challenges of the framework that we're currently operating in. This is obviously publicly held data. We present this as NHS Improvement as part of our quarterly annual update. And this kind of highlights the quantum of the, what I term the quantum of the risk that's held by the system in terms of delivering the kind of portfolio of services that you do day in, day out. The headline from this is obviously always invariably around the number of nursing vacancies that exist across the system. But actually, when we start to look at the global impact of the current vacancy position within the NHS provider, it is a significant position of risk, notably around some of our clinical and professional staff. But as you can quite rightly identify, we have significant numbers of vacancy data held in relation to individual providers in other professional groups around this. So whilst the kind of overt focus of policy and support is around both nursing, AHPs and other professional staff, including medical staff, actually the risk is much broader than that in workforce terms in terms of the delivery for different parts of the system. Now, the majority of the caveat around this is the majority of this gap is mitigated off against utilisation of temporary staffing solutions. And whilst one arm of our business is supporting the system in terms of reduction of use of agency, trying to migrate to bank and support, we actually can't necessarily stand here and say that actually this is not a challenging position because of the nature and the scale of the vacancies that individual providers are things. And the variation in that is quite significant. So we have some trusts who have 3 or 4% vacancy rates, and we have some trusts up towards 25, 30% vacancy rates. So it is hugely variable, and variable up and down the country in terms of the different sectors and the environment we operate in. So it's kind of important to highlight that in terms of the position that we're in. Now, again, to look at some of the kind of variation in that position, I think it's really kind of important to understand that what we see is both sector-based variation and regional-based variation. I think the general view is that your vacancy rates will be higher the more south you are. But we have some particular challenges in mental health and learning disability organisations, and also some particular challenges in terms of the experiences of colleagues who work in the ambulance sector, which I'll come on to at a moment in terms of exploring what this is. So we know that there is a workforce supply constraint in lots of areas of our professional work that's leading to a number of challenges in relation to the vacancy position. There are certain sectors and there are certain parts of the country where that is amplified and far greater problem than we see elsewhere within the country. That is also things in terms of the variation. If I look at other workforce data, we actually start to see again a quite significant distribution in terms of the risks and other areas. So when we start to look at things like sickness as an example, the acute sector has one of the lower sickness records. Now, I get the issue around collecting data, and I know there's an underreporting within medical staff. I completely get that. But so before you go, hang on a sec. I do understand that, but if we were to just look at the kind of data that you present back through into the system, we do see some quite significant variations within the sickness data presented. So we know that we've got a quantum of vacancy issue. We know that we've seen an increase in the kind of vacancy, in relation to the sickness challenges within individual organisations. We also, again, in terms of the kind of sickness data, there is quite a significant variation between sectors, but also importantly, there's quite a significant variation in grade. And actually, I think it's important to understand that some of the strategies around this are so we have often some of the lower vacancy rates within our band 2 to 4 cohort, but yet we have higher sickness rates within those group of staff. We have particular risks and challenges in relation to the sort of band 5-6 cohort across all professional groups, and have slightly lower kind of rates. So in terms of understanding the data, I think it's important to understand what you experience from a frontline perspective is mirrored almost across the kind of national picture. As many of you know, we've launched a lot of work in relation to retention across the system. It is the earliest or the most important intervention that we can apply in the short term whilst other supply routes start to come through. So tackling both sickness absence as well as also tackling retention is one of the kind of levers that we are able to deliver in terms of improvement. And the reasons why are because there's quite significant shifts. If I look at kind of registered nursing as an example, the kind of turnover rate, i.e. those people churning and moving around the system, has gone up from about 10% in 2009 to just under kind of 14%. There's tens of thousands more individuals. The variation in turnover is quite significant. It ranges from about 4% right up to 30%. Now, don't get me wrong, not all turnover is bad. We actually should have a kind of sweet spot. There is a lot of regional and sector-based variation in that. But actually, low turnover is as big a problem as is very high turnover. If you imagine working in an organisation, the HR leads within this room will know that if you've got a third of your staff in transition at any one point of time, that is an operational risk to handle in terms of the physical quantum of people that is in the case. But most concerningly is actually the leaver rate. These are people who are leaving, so we've stripped out TUPEs and transfers and reorganisations from this data, but this is the people leaving service. These are people who are leaving the NHS. Yes, of course, they may go off to work in private sector, but importantly, actually, a lot of them don't. And this isn't a retirement bubble, so we've analysed the data. People often say to me it's a retirement bubble. It's not. Actually, the greatest level of turnover and leaver rates that we experience in registered nursing within the NHS at the moment is those that are less than 45 years of age. So when we start to look at some of the issues and challenges around retention, we actually find, again, it's reciprocated a lot across the different parts of the sector. Again, in quantum terms, it's disproportionately exposed to the acute, large acute, but actually more important in quantum terms, mental health and learning disability trusts face a far greater challenge in terms of their turnover and retention of staff compared to any other part of our system. And that's important to understand because actually we've seen quite significant declines in the number of overall staff within those kind of sectors. Right. So, this is maybe slightly naughty of me, but I went away and did a little bit of an audit of board papers looking in and around the safe staffing. So, no names shall be mentioned at all in relation to this, but I took a sector and regional-based approach in terms of identifying a number of organisations. I applied the kind of workforce safeguards approach in terms of things, and I would like to play it back to you today in terms of what I kind of found in relation to doing a thematic review in relation to the audit process. Right. But before I do that, I kind of want to describe to you what I think good looks like in terms of board governance and oversight in relation to that. I know Lorna is going to come and do some work in a minute in relation to kind of the technical nature and the governance, but this is kind of just my lens. This is my lens as a kind of chief nurse looking at what good looks like. A good trust will look at its workforce in the round and not just specifically looking at one individual professional group. And actually very, very few organisations look at workforce. They look at nurses, they might look at doctors, they might look at AHPs. They'll often is important to cover all wards and departments. We're very myopic. I came from an acute provider trust point of view. We analyse to the nth degree what goes on in wards, but do we apply the same lens to outpatients? Do we apply the same lens to radiology? Do we apply to the same lens to other types of clinical department? Again, we can sometimes be kind of challenged in terms of the approach we do that. Often missed out in kind of board's oversight in relation to staffing issues are theatres and other types of specialty department. And like I say, completely missed are things like outpatients and radiology. So again, I'll come on to some kind of data in that in a moment. the best way to get across to a board a complex problem, and yes, boards are hugely variable, but I know non-exec directors are often really, really interested in getting into the nitty-gritty, in understanding the data that sits behind this. And some of the best ways of approaching this is absolutely playing back to the board, the actual data themselves, whether that's through kind of a formal board meeting or board seminars, and actually providing an opportunity to be able to get into the different tools that are available, explain them, why they're important, what is the triangulation, because that will enrich and develop the kind of conversations that go on in boards. There has to be a clear link to quality outcomes, the operational and also financial performance achieved on individual wards and department areas. Again, looking at kind of workforce in isolation from other types of business approach are a huge challenge if we don't get them right. That absolutely, I know it's a trite phrase, but there has to be ward to board. There has to be a clear link right down to what goes on and what's understood at board, right down to individual challenges within things. And I'll jump a bullet point and say a rationale and approach. So this is my term. This is not an official LHSI term. This is my term. But, having your list of worry wards, as a chief nurse, I often had a number of wards and departments each and every month that really worried us as an organisation. And that wasn't just about the nurses. It was about the culture. It was about the leadership. It was about the delivery. It was about the performance. Having a rationale to do that, other than a kind of gut feeling and some evidence to support that, I think is really important for a board to understand. In big organisations, there will always be 2 or 3 areas that will kind of give you a sleepless night. And having some objectivity about assessing those parts of the organisation is really, really important, so they don't become surprises at board when Ward X or Department Y fall over. And it is important to make sure that those kind of links lead to action. And those actions for a board are not necessarily about micromanaging individual performances of areas, but understanding risks and the issues and mitigations that might be applied to that. So here's the kind of data. So actually, 84% of trusts in the audit publicly stated that they were completing a twice yearly assessment. 84% of those organisations examined pretty much nursing. None examined medical staff, none examined AHPs, 58% examined midwives, 58% examined paediatric nursing. So when I talk about variation and I talk about workforce, it kind of lends itself to the kind of parallel, which is that at boards, we kind of tend to just focus on the nursing staff and not open up that conversation into a broader workforce picture. As critical are our AHP colleagues and as critical are our medical colleagues for the team to be part of that. The areas of focus, again, 100% examined all of the wards within their organisation. 84% examined emergency departments, but only 33% examined outpatients, theatres and radiology. And again, if you look at the kind of CQC approach in relation to inspection, outpatients, radiology, and these sorts of departments are becoming much more of a focus in relation to the kind of staffing and experiences of delivering that. What tools? Well, only a quarter of trusts use the evidence-based tools that were available to them across all of their areas, whether that's maternity, paediatrics, whether that's in medicine or nursing. Only a quarter of trusts use the evidence-based tools. So again, this is kind of a real challenge for us in terms of doing that. The remainder use some tools, but not all, and never necessarily presented the kind of data of those tools provided. In 3 trusts, there was no evidence of any tools being used whatsoever. And that wasn't just their public board papers. I went through their board minutes, their more notes. I went through everything to ensure that I could kind of get a composite view in relation to do that. All trusts had the data in relation to the fill rate on their wards and also, importantly, CHPPD. Now, this is kind of fascinating. Only 50% of trusts ever set themselves some sort of threshold within their organisation on performance in relation to kind of things like fill rates, as an example. And interestingly, the range was quite significant, between 80 and 95% of fill rates for their clinical staff within those kind of environments. So again, there's quite a lot of variation at all. Good to see 84% of patients link their staffing to their quality matrix, but actually only a quarter of trusts flagged any risks that were linked to their risk register or their BAF. Now, these were organisations that were operating quite significant operational challenges in relation to vacancy positions, etc., but only a quarter linked that to some board-level understanding of the risk they held. Accountability, and the chief nurses in the room will smile at this, but 100% of trust noted that the CNO was the nominated accountable officer in relation to staffing. And it kind of tells us something, doesn't it, in relation to the kind of things that Emma's talked about in relation to where we've got to. But we have to broaden that conversation out, hence why the policy has been designed as it. In 16% of cases, when I looked at the minutes of the meeting, the board paper in relation to staffing was passed without any comment or any action whatsoever. So it was just noted, even though in that report was some serious operational and clinical challenges in relation to the portfolio. And 16% of those trusts, there was no minuted action or even any risks identified in relation to managing their workforce portfolio. So I think when Emma does start to talk about some of the variation we have in practice, and we actually look at the adoption of good evidence base that we see already, actually we can notice, even by simply going on and look at what's publicly available, and actually should be quite a transparent conversation with our local communities and providers, we see quite significant variation. And actually, in some cases, it's very difficult without going to see the board themselves. Actually, the question arises is, does the board really truly have a handle on that risk? In some cases, there is some clear evidence that the board hasn't necessarily understood those risks in detail. So in terms of the kind of board, in terms of looking at staffing evidence, it's really important that, the numbers are really important. And I know many of people will say to me, well, it's not also about that, it's about patient experience. Of course, the outcomes are absolutely vital. But there is sufficient statistical and tool-based evidence to support objective assessments in relation to staffing, good or bad. And I kind of preface the fact that I completely understand the operational challenges in working in a context where we've got quite significant challenges in relation to the workforce. But I do disaggregate the really important point. There is one thing operating in a supply-side constraint market where we've got serious challenges in relation to our workforce position. There is a second thing, which is actually being able to articulate what those risks mean for you and your organisation, and importantly, what you're going to do as a response to do that. And we'll come on to other examples about whether or not we close capacity, whether we intervene different mitigations. But actually, my perspective is that actually we need to quantify both what we operate in, but importantly, what that means and translates into operational experience. And the best way, from my experience, to do that is obviously through statistical evidence and the tools that we have available to do that. It is absolutely fundamental that is involved in some level of triangulation. Please absolutely take away, particularly when we look at the NQB document, is the triangulation between the statistical and the evidence-based tools, but professional judgment. Clinicians will tell you when things are challenging, and that's really important to make sure that that's part. And in addition to that is the outcomes that are achieved. And I'll come on to some examples in a moment that maybe might start to get you to start to think about how that triangulation works in a little bit different. Is the acceptance of the evidence, actually, and again, I say this not that it's a kind of easy thing to do at board level, because actually we've got kind of finance challenges, we've got workforce challenges, we've got operational challenges. Trying to have a unitary board discussion about the risks we handle and what to do is really very, very difficult. Accepting the evidence that presents is really hard to do. And it's also important to do that. One of the things that we kind of advocate is absolutely making sure that organisations have really, a decent analytical support. It's really evident when you start to look at this. It's being sometimes done on the hoof. It's sometimes being done without necessarily good support into it. So analytic support is really key. Board preparation is absolutely important to ensure that there's a really broad case discussion in relation to the ability to do that. Again, board seminars, other types of informal environment are really critical to get that right. And importantly, is the kind of important, the organisational impact is being able to articulate. One of the key challenges I had as the chief nurse was absolutely making sure whatever analytics and assessment we made at board was meaningful in terms of things. So when we were discussing business cases in relation to investment strategies in wards and departments, actually the team used to come to board to be part of that, to get that kind of clinical view into the kind of board discussion or the chief officer group was kind of critical to do. So engagement within the organisation and understanding the impact around decisions and building a strategy for that is kind of important. And I'll come on to an example of that in a little while. So kind of looking at what looks good is when we kind of describe a kind of ward to board, is kind of pigeonholing in three kind of key tranches, really. One is kind of the strategic requirements of the organisation, and all of you who kind of work at board or sub-board level will kind of understand that actually there is quite a lot in this space to understand in relation to what workforce means through your board assurance framework, ensuring that you've got the right sufficient numbers to deliver your organisational strategy. You've actually got an agreed model in terms of the care standards and also the resourcing priorities. Now, of course, I appreciate there's 101 assurance mechanisms out there through CQC, NHSI, NHSE, etc. And actually what is important is making sure that those plans fit your approach. And I completely understand some of the difficulties in making sure that there is a complete alignment. Now, sometimes we do see within these kind of presentations and plans is actually there is sometimes a disconnect between what the strategic intent of the organisation is and what the tactical and operational plans feel like when you start to look at the workforce. A good case example is where you see an organisation presenting a reduction in the number of nursing that seems to map or mirror almost identically the balancing item on the finance cost spreadsheet. And that does happen kind of frequently. So it tends to suggest that there is sometimes a disconnect between the kind of intentions of board and also, importantly, the kind of outcomes that are achieved. The tactical nature is really important because actually that's where a kind of deep engagement can occur with kind of frontline staff and leaders within the organisations, is translating that strategy into different tools in terms of both budget setting, ODP plans, and ensuring that those kind of pathways or service changes are reflected within different models of care. Now, for a lot of people will say, well, actually, we kind of do this. Why are you kind of teaching us to kind of suck eggs? Our experience from kind of the data is these kind of approaches are not often well embedded within organisations. Some do that exceptionally well. Some are very challenged in relation to this. But also important, there is oversight in relation to what you decide in terms of your strategy, the tactical deployment of the resources that you do, and the day-to-day management of how that's delivered. Because the important thing is, for a board, is quantification of risk, and also the rapidity by which the board can get sight of the risks as they evolve. Everybody knows the dynamic nature of workforce and challenges. You know, a ward can go from being well run to being a huge challenge from one shift to the other. The issue for the board is making sure that systems and process highlight that risk early, the mitigations are applied accordingly, and it's not 3, 4, 5 months down the line that one of the worry wards falls over and there's been no board oversight in relation to the risk as that's escalated. So that kind of process is kind of really critical to get right. Now, this is kind of a slightly busy slide, but it kind of trying to represent the two bits for me, which is kind of the techie data on the one side, which is the kind of tools and things that people start to use in relation to determining the staffing types of solutions, versus the kind of operational data and the patient data. And again, sometimes we've seen within organisations that these are often dealt with in isolation. So we see some parts of the business working to one set of principles, whether that's kind of safe staffing, whether that's different tools. On the other hand, they're being held to account in relation to other types of principles, whether that's kind of fill rates or e-rostering problems, or whether that's a financial solution. Bringing that together through a kind of sub-board structure is really kind of important. And one of the keys I put in there, QGC and F&P, people use lots of different names, but we can't disaggregate the quality impact from the financial impact in terms of the sustainability. And my kind of preference is absolutely to ensure organisations are having joint conversations before board, exposing the issues and challenges in both arenas, which is actually, you know, you can deliver a safe, sustainable and quality-based service that doesn't necessarily blow the budgets, but actually it's important there's a clear oversight and understanding between the finance functions, the workforce functions, nursing, medicine and others, and exploring and understanding those issues before they get to board. So taking all of those things in place, the key thing is you collect all of these now. The issue is, how do you bring them together in a conversation, and where do you bring them in a conversation that ensures that those things are able to be discussed and talked about? So what about kind of using the data? This is kind of my real world data. I've kind of used this from my previous organisation where I was kind of chief nurse, in terms of the granular nature of stuff that I was kind of presenting to the board. And actually, these are kind of two graphs that look at kind of, particularly this is looking at an inpatient-based model, looking at some of the variation we had in relation to the kind of acuity modelling that we were doing with different parts of the system. and actually presenting to board some of the significant variations and shifts we'd had within the board profile in terms of the presentation. So again, it's about having conversations, those that are below the line versus those that are above the line. So having the data enables us to have a really gritty conversation about where investment was required, where de-investment was required, and where actually service change and skill mixes were more appropriate to do. So we could build risk-based models to be able to do that. But without having an objective assessment to do that, it's extremely difficult to really articulate to often non-clinicians in board in terms of the scale and the scope of the challenges that different parts of the organisation had. And taking that data, I think, is kind of really important to make sure that, again, all of those things line up to make sure that what is evidence within the operational plan, i.e. what you set out to do as an organisation to deliver your strategic intent of your board, is aligned to the operational requirements to do that. So again, we do see anomalies within the board data where we see a declining number of nurses in an operational plan that says that you will start you'll end the year with probably 2,000 or 3,000 whole-time equivalents less than you started the year, yet your overall demand profile will go up by 2.5, and there's no clear evidence in relation to how that efficiency program will be delivered. So it's not to say that any answer is right or wrong. That entirely may be the case, that a reduction is appropriate. But without the granular detail and understanding and exposing of the risk at board, it's very difficult to see whether those plans come to fruition or not, which is why the business planning process aligned with the tools is really very, very clear to do. And clearly, importantly, to be taken through the board governance process. So by the time it gets to board, you've got a clear idea of where the challenges exist, what the mitigations might look like, and also importantly where the risk sits within different parts of the organisation. Now I can't bring you on to this slide. This is a real world slide from something I took to my board in terms of exposing the kind of nature and the scope of the problem. So it looks kind of busy. I will kind of explain it, but actually what you have here is a number of inpatient wards. We've put an arbitrary cross point on there which actually looks at trying to expose a particular issue, which is actually that those wards below the line often have very low, very good outcomes, very, very good outcomes in relation to the delivery of their service. Those that are above the red line on the horizontal axis are those that have got quite significant challenges. And actually, left and right is the kind of acuity data modelling in terms of discussing about how far they are away from their kind of ideal establishment. So the reason for kind of highlighting this is that we actually have some really interesting kind of data in here. If we look at the different quadrants, we've actually got a number of organisations on parts of the organisation on the bottom right-hand side, which absolutely have sufficient numbers of staff based on their modelling and actually delivering outcomes. So it's kind of interesting to look at this group and identify what's going well within that organisation. The bottom left identifies those that actually are delivering quite very good outcomes within the organisation, have something interesting going on in terms of their leadership and organisational model, but actually, according to the data sets, have actually got less than ideal establishments in terms of their organisational model. Above the line is where risk sits. So it's a sliding scale of risk that actually we've got some organisations, parts of the organisation that absolutely are doing have got higher levels of staffing according to their acuity modelling, but actually are delivering worse outcomes than other parts of the system. So again, it's about a conversation where to go. And the top left is where those challenges sit in relation to those parts of the system that have got a serious intractable problem. And we used to use this kind of sentinel graph absolutely as part of a board discussion in a public environment to actually start to think about where the risk sits, where the strategies, what does service change, what does skill mix look like in these environments. And through that was kind of an important part of what we did, linking quality to modelling and the data. There's loads of kind of benchmarking capabilities available. In the old days, and I'm kind of looking at director of nursing colleagues in the room, we used to ring each other up and we'd say, can you send me all of your kind of establishment data so we can measure one part of our organisation to another? And there used to be like secret clubs in different parts of the region where people used to share their data under cloak and dagger methods. And actually, to be fair, you don't need to do that now because actually model hospital. So hands up if you've gone to model hospital. Fantastic. How many of you kind of use it as a kind of operational tool, go in there, look at it very frequently? Yeah. there's a huge amount of plug-and-play capability within the data sets within Model Hospital that enable you to go and look at yourself and many other parts of the organisation. It is just somewhere to go to do that piece of work. I am not expecting people to go, oh, well, I should be at 7.5 on an aggregated CHPPD because that doesn't work. My organisation needs to be at 6.5. It should be part of the conversation. Board members should be able to access this, to be able to start to identify conversations about why we've got some variations in practice. Why are we delivering good outcomes when actually our input model is slightly different to other parts of the system? It's not a right or wrong answer, but it actually provides you with the ability to benchmark in relation to a number of areas. So this is kind of sickness absence, which is again a real world example from an organisation. We can look at that natural distribution. You can see where you look in terms of your distribution. Now, people often say to me, well, the whole point of this model is to try and get people down to an aggregated mean. And if everybody was at the average, we'd all be fine and dandy. No, that's wrong. The reason for this is to look for two things. One is unwarranted variation, things that don't make sense. But importantly, it's just as important to find warranted variation. And the practical example I use is gynecology. Gynecology across many, many parts of our system in terms of the standard models, in terms of the application of those kind of service models, often have lower CHPPD when we look at them as a cohort compared to our major large teaching cancer centres. So if your CHPPD in gynecology is 8, I'm making this, no, let me get the right number, it's about 12, compared to core district general service models, which are around about 6, that does not mean that everybody on board should take you from 12 down to 6. Because it means that you need to go and look at your system, and you might have warranted variation because your skill mix, your case mix, etc. generate that. So we're looking for warranted and unwarranted variation to identify the different models of delivery, not necessarily aggregating to a mean to be able to deliver that. Helpfully, within the model hospital, it does enable you to look at some level of cost base and kind of support model. So, you know, they actually look at the weighted units to look at the kind of cost comparison. It absolutely is important to look at this, but again, it looks at a kind of conversation within the board to look at the different types of model, because you know it's not perfect, but it does give you the ability to start comparing different models and different approaches when they're seen in a triangulation in relation to all of the other benchmarking data. So rather than ringing around, every single provider organisation is on Model Hospital. The new better data means that you can now drill down to individual ward level. And please, I'd like to put a massive thank you on the table for the Model Hospital team. So how many wards have we got in the NHS, do you think? Hospital wards and service lines? It's somewhere between about 8 and 10,000, depending on how you name them. Okay, how many names of wards have we got for those 7? Yeah, well, it was 54,000, right? And the reason is because we have multiple different systems in your organisation. So even in your own hospital, you'll have Bluebell Ward, and you'll have BL1 in one system, you'll have BL7, and it will still be called Marjorie Ward in some other system in the things, or it will be called B7 West. So trying to kind of merge those is quite difficult. So again, colleagues have fed back to me that sometimes the specialty mix doesn't work on Model Hospital. Actually, if you do find those anomalies, please do tell us. We have engaged with your information analysts to try and do that as best we can. If there are some anomalies, please let us know. We can kind of align them. We do know that wards move around. We've had one big teaching trust who's contacted us, is doing a complete configuration of their wards, and we've gone into their organisation to understand that their specialty data lines up with the benchmark data on the national picture. So if you find anything like that, then please do let us know. So what kind of difference does it make by kind of exposing some of those kind of challenges on the wards? Well, actually, this is kind of, again, another real-world example from my experience. You know, we wanted to develop a different model of care. We'd identified through benchmarking that there was a need for any kind of investment strategy in there. And actually, when we started to look at the risk profile, it was very evident that actually those kind of investment models needed to be done. Acuity was very low, non-sensitive indicators, but actually they were venting pressure in terms of the use of enhanced care within those kind of environments. There was an obvious economic as well as also clinical decision in relation to an investment strategy within the organisation. Actually, in another environment where we had a very similar pattern, actually we started to look at the skill mix and also, importantly, the clinical pathway. So when we started to look at the different changes of our admission profile, the demographic issues and the dependency shifting, because we had a very similar pattern in the data, it wasn't necessarily an investment strategy. We actually looked at redistributing some of the resources from elsewhere in the system including roughly a 60k investment within from another part of the organisation to be done that. Remodelled the skill mix in relation to both the shift patterns, again by engaging with the frontline leaders. So what was presented as two clinical environments that had identical data pictures, the risk profile, the approaches in relation to kind of the improvement strategy within those places was very, very different based upon a granular understanding in relation to the clinical teams that we were working with. The kind of final section I want to focus on, which kind of comes out within the kind of report, is around kind of new role support. Now, I kind of don't make an apology for this kind of slide being kind of a little bit busy, but when I kind of trained as a nurse many, many years ago, it's kind of fairly evident that what a doctor nurse did and what a nurse did and a therapist did and kind of what people did in the system, the clinical model has changed quite enormously in terms of what that actually means on the practical day-to-day. Some of that has been driven by new roles into the system. Some of that has been organisational change, and also those organisations taking different approaches to workforce within their system. What we kind of have over here on the left-hand side is that actually when we look at kind of the band 2 to 4 workforce support space, we've actually seen quite a lot of innovation in this. We've got the use of therapy assistants, we've got multi-mode practitioners that are a bit nurse, bit therapist, bit IAPT in some cases in mental health trusts. And importantly, in and around the kind of registered space, again, we've got lots of kind of transition around different approaches that organisations are taking in relation to kind of skill mix as an example. So we've got AHPs now leading clinical teams, rather than necessarily just other AHPs. We've got in rehab settings, we've got AHPs leading wards of nurses. And also we've got the boundary space between the kind of nursing assistant type roles and the assistant practitioner roles, and now when they qualify the nursing associate. So organisations are taking a pragmatic approach in relation to the global workforce challenges they've got, trying to articulate them into kind of approaches to delivering kind of skill mix change. And we see equally at the same other end of the spectrum. So when we start to look at kind of often around the kind of medical workforce space, we've had a long history of specialist nursing and advanced practitioners. We've got physicians associates starting. We're starting to see the clinical team evolve and model really quite significantly. And if I kind of like, these are kind of case examples. When you get the slides, it's kind of a lot of detail in there, but they give some really good examples where lots of organisations are actually changing their approach to skill mix design by utilising these roles effectively. Importantly, they're doing so and actually doing it in a really kind of systematic and approach and meaningful way. What is kind of interesting is actually we do this wholesale clinical change, but invariably we very rarely understand the risk and the mitigations that need to go into doing it. So one of the recommendations within the Workforce Safeguards report is where you have a significant and material change in skill mix, actually the organisation should be applying the fairly standard quality impact assessment approach in terms of understanding what that means, the impact for staff, for patients, for outcomes, finances. So the organisation is clearly understanding before it goes into these skill mix changes whether it's the right thing to do, what to monitor, and if it's not going well, what things. Invariably within the NHS, we're pretty quick to go for a workforce solution and change something without necessarily really starting to really articulate and understand what the risk to do. Again, particularly around the kind of the higher clinical decision-making space, we're seeing lots of transition into different kind of skill mix models in different parts of the system, the use of physicians associates, and also advanced clinical care practitioners. It's really important that organisations, before making these changes, are fully articulating and understanding the risks that might things. And in most cases, they are often minimised, they're often very low. But actually, it's important to have a conversation that actually, if we are going to change our neonatal unit from tier 1, from being a relatively fragile junior doctor rota to advanced neonatal practitioners, that the organisation understands what those transition arrangements and risks might look like. Has anybody done a skill mix redesign and done a QIA? Can you put your hands up? Yeah, a few. So when we kind of went around the country, we found some really good case examples where trusts were being very, very upfront and proactive in relation to understanding those risks and putting in good, strong, evidence-based decision and support tools for boards to understand what that might mean like. And it does kind of lead us to a conversation, which is, again, within the document, is trying to give some case examples, but also a kind of framework in which people to do different things. Now, one of the key challenges I always faced as a chief nurse was that some or all parts of the system were under different pressures at times. And often when we spoke to the frontline clinical staff, the pressures of demands of different flows required pressures with challenges. So because of the nature of the way my wards were structured, it was relatively easy to close all or parts of wards at different points in the year. Now, that is an extremely difficult decision to make within an organisation, because you've got ops colleagues saying, please do not shut any capacity whatsoever. Even 10 beds gets us through the night, and I had 1,400. Where there's finance colleagues saying, yes, no, don't stop at 12, close 24, because, you know, we'll save all of that kind of money on it. So I understand some of those dynamics, but actually what's important is having a methodology within the organisation that allows that cross part of organisation discussion about what's the merits and risks of doing that and building a plan. So one of the key things I always found a massive challenge was when to open capacity. Ops colleagues would like it timed, particularly near to winter. Sometimes it was actually about when things were going to be closed. And again, there's some good examples within the document, and again, we'll talk about some of them a little bit later on in relation to different approaches in relation to when to open capacity, what kind of measures should be put into place to do that. Again, when I was chief nurse, I remember opening a ward. We had a long debate about what was a sufficient level of temporary staff versus permanent staff to work on an environment. And we had a professional debate about it and said that it should be around about 60% permanent staff versus 40% temporary staff. Now, those sorts of conversations go up and down the country all the time, and I've seen some which are 100% temporary staffing when opening additional capacity. But our risk appetite was much lower, and we went through a risk assessment process to determine what that was. So there's different places to do that. There's also the challenges around closing it. And I know a couple of examples where colleagues have had to take the very, very difficult decision to close parts of organisations, parts of services, or even stop entirely service models. And again, the document's helpful in terms of describing some approaches in terms of the objective nature of those kind of assessments and the data that does. But it's really important to understand that it's not necessarily the decision that's you shouldn't do, because you should. It's the framework. I remember being interviewed by the CQC. I'd closed a ward or part of a ward, about 12 beds, for operational and staffing reasons, and a good hour of my interview with the CQC was how had I come to that decision? What documents did I have? How much was board cited on it? This was just closing 12 beds out of 1,400. But it was really evident they wanted to look at process. They wanted to look at how it had been signed off, what engagement had taken place, how it understood that. Did the frontline understand the decisions? What were our criteria for reopening? What was our criteria for keeping closed? And what was our criteria for closing even more? So it wasn't about the decision. It was the process and the governance that kind of fitted in around that was really, really kind of evident. So I've only got kind of a minute left before I hand over to my colleague Miles from Maidstone and Tunbridge Wells. But I hope this kind of session has really kind of brought out some of the issues and challenges and why the policy was designed and alongside some of the really important challenges that we have within our providers, recognising on one hand the workforce issues that you deal with, but also importantly kind of focusing in on process, the board, and broadening out, importantly, broadening out the responsibility of workforce to the wider board rather than necessarily it sitting with one or two executive directors that can be, in some case, a pretty lonely place when you're fighting a number of fires on all sorts of fronts in relation to the workforce challenges within the organisation, kind of building across that concept in relation to the unitary board. So I'd just like to say thank you for the team who've helped me kind of bring some of this together. Obviously, I've kind of hopefully shared with you some of my own kind of personal experiences in trying to work within this kind of space and some of the challenges that I have. And I think I can probably take one or two questions. Tony, am I allowed to do that? Yes, one or two questions before we finish, and I invite my colleague Miles to the stage. No, I got out of that one, didn't I? Excellent. Oh, lady in the middle. Yes.
Do QIA and EIA when we're looking at service transformations in a kind of turnaround context.
Yeah.
So my question, I guess, is are there examples of people who do them really well? Because when you're doing them, you can quite often just get into a bit of it's part of the project plan and you have to do it. So I'd be kind of almost interested in anyone that can offer support or guidance in doing good quality QIAs and EIAs.
Well, I may be biased, but I have two of the finest people around board governance working in my team, Lorna and Becky, and Lorna is here today to do a session. Lorna, will you cover QIA within your governance discussion?
I think she's just left the room.
God.
Yeah, I think she is, yes.
But she is going to cover QIA.
Now.
She is now, anyway. But yes, you're right. We often think of quality impact assessment in kind of quite, CIP terms and kind of service change terms. But actually, when I start to look at some of the kind of changes we're making in workforce, whether it's changing of service models, skill mix redesign, investment strategies, very rarely do we see the level of analysis that goes into a QIA for, say, a CIP versus what we do when we're quite materially changing some of the risk profiles that might exist in a ward and a department. So yes, we do have a number of really good case examples, and I think Lorna's going to go and describe actually what that kind of process looked like, what does kind of good look like as well. But if there's a specific support requirement, please come and see me and we can kind of support something like that. Karen.
Hi Mark. I just wanted to ask a question. You mentioned about data analytics are really important, and I absolutely agree with you. But there'll be a number of us in the room that are in organisations where we don't have that level of expertise or maturity in the teams. Are you able to offer us anything or point us in a direction where we can pick up that sort of expertise?
Yes, absolutely. So a lot of you will have information teams within your organisations. A lot of you will have really good analysts, but they'll often be hugely overburdened with requests and things. So we've got a workforce analytics team at NHSI. We've got a team of 4 or 5 people who've got huge experience at provider level, and also who can come if you have a specific request to look at your kind of reporting ways, kind of analytics you might want to apply to the problem. We can come to your organisation and support you to do that, or we can do it remotely, and we're also available to offer kind of remote feedback if you want us to look at board reports or governance models. Again, we can do that offline, so that's no problems at all. Great. Right, one more question before, yes.
Oh, hello, hi. From NHS Improvement, hi. I just wondered if you could just say a little bit more about the SOF and how the work that you're describing today links with the SOF, so we can understand what that regulatory framework might look like in association with this element.
Yep. So assuring safe staffing has been bolted into the existing SOF framework in relation to the delivery of the service model. So we haven't revised SOF as a relation to this. We will not be applying a risk-based model to your organisation that will change your SOF. This is the first year of our assurance process in relation to safe staffing. So what we're looking for organisations to do is to provide a comprehensive overview. So in the first year, we're assessing whether or not you've adopted this framework, that the kind of inputs and outputs are described at board level, so are you taking the right type of information? And we will work with you over this next year to enable that to get that right and to sharpen it up so we can get the consistency across the system. Into year 2, what we also are starting to want to explore with trusts is to identify the risks in the system. And this is working with individual trusts and systems to know which organisations are particularly stressed under this kind of framework. So once they've done their assessments, they've identified where their risks are they greater or larger than other parts of the organisation? So we can have a sliding scale of support right through from a kind of soft 1, which is kind of leave you alone, well done, crack on, right down to soft 4, which is where we kind of might need to kind of help and support you in making those decisions. The moment we do that, but we tend to do that through the kind of regional assessment, which is often purely based upon the regional knowledge and local knowledge of that organisation. We want to objectively measure this so we know that the consistency is being applied. So it will be in 2 phases. Year 1, embedding approaches within organisations and ourselves. Year 2, probably moving to a more risk-based approach and identifying those challenges within organisations, and work with you to kind of make sure that that's delivered. Great. Well, thank you very much. Great questions. I'm happy to take others a little bit later on. It gives me a really great pleasure to invite Miles Scott to the stage. Miles is the Chief Exec of Matron and Tunbridge Wells NHS Trust. A significant experience as a leader across the system, and I'm really delighted he's been able to make it today to kind of talk through his experiences within his organisation of practical implications of delivering improved workforce. Thank you very much, Miles.
Thank you. Thanks very much indeed, Mark. Just before I start, I would really like to get a bit of a feel for who we've got in the room today. So, because I saw the list of who's invited, but that's not always the same thing as who shows up. So, and I think it might also be interesting for you all to see who you all are. So, who here is a kind of a Ned or a governor? Okay. Who here is from a nurse leadership position? That's most people. Workforce? That's most other people. Any other professional group? Okay, a couple of AHPs and one or two others. That's really, really helpful. I think the reason I was asked to talk to you today, apart from being a kind of jobbing chief executive, is that it would help if I turn these the right way around, wouldn't it? So, as well as being a jobbing chief executive, I had the privilege actually of chairing the Nice Safe Staffing Committee 5 years ago, so I spent quite a lot of time looking at a lot of these issues. So, what I'm going to do today is I'm actually going to start with that, and I'm just going to give you a few reflections from that experience 5 years ago. What I'm then going to do is talk a little bit about what I think some of the kind of the board and actually stretch that out to governors, what some of the board considerations are and what we might be looking for in taking forward this guidance. And then I'm going to share with you some of what we do at Mason and Tunbridge Wells, or MTW as we call it, not because I think we're great paragons of virtue, but because I hope it will begin to surface both what are some of the things that everybody in this room has actually achieved over the last five years in relation to safe staffing, but also what are the challenges, and what I'd like to do is actually get you all to start to voice some of the good practice, but also some of the challenges that you're currently working on. So if I start with the Nice Safe Staffing, I mean, it does feel like this was the kind of the guidance that dare not speak its name for a while. We worked kind of furiously hard. We published stuff. We developed other stuff that was ready to go, and then it was all a bit inconvenient. And as a consequence, it was kind of rather unceremoniously dropped. And it's been interesting actually on a personal basis to see how it's slightly come back into vogue actually, and you are at least allowed to read what was written, and some of what we did has been built on in terms of later guidance, and I think there are some reflections that are quite worth picking out. So the first for me was this whole question of evidence. What evidence really is there around safe staffing, particularly in nursing and midwifery? And there's an awful lot of published stuff, but actually the quality of a lot of that published evidence was quite difficult to use in the way that I think the government had anticipated that we would use it. So it's no great secret that the Secretary of State at the time, Jeremy Hunt, was very keen that we came up with some nurse staff ratios that we could publish, and that everybody in the NHS could be held to account to, and the evidence didn't point us in that direction, and there were a lot of people in the kind of academic community who were saying, well, the evidence isn't really there to come up with guidance, national guidance at all. But I think that's not right. There is a lot of published evidence out there. It is of differing quality. But there are a number of insights that come from the evidence that's really worth holding on to, and really worth making sure that people in your board and, frankly, nurses and other staff in your organisation are aware of. And I've just picked out here, I'm not suggesting these are all the bits of evidence there are, or these are necessarily the most important ones, but these are ones that stuck with me over the last 5 years, things that really kind of came home to me, despite having worked in the NHS for 25 years at that point, that really came home for me as a result of doing that work. And the first one was this whole kind of concept of what is a staffing sensitive indicator. It's clear that falls and pressure ulcers are seriously sensitive to nurse staffing levels, and they are the indicators that are really worth looking at in terms of trying to understand what's going in your nurse staffing levels. Other quality indicators mostly aren't actually very sensitive to staffing. That doesn't mean to say that you shouldn't use them, that you shouldn't look at them. It doesn't mean to say they're of no use. But what it does mean is there are lots of confounding variables, and they they are unlikely to do more than raise a question for you, and actually getting people like Ned's, and even getting, frankly, in our experience, some of the frontline staff really to hook on to the importance of what some of these indicators are, and which of these indicators really link to staffing levels. I think another really big message that's comes from all of the international evidence is that the links between nurse staffing and safety are absolutely driven by registered nurse numbers. And there's some really good work internationally around the role of non-registered support professions, and frankly the evidence is very clear that when it comes to looking at safety issues, it's the registered nurse numbers that count. Now that may be really obvious to most people in this room, but I don't think that is necessarily as obvious as that to everybody that you're engaging with. And you know, somebody who works as a support worker on a regular basis, that isn't to suggest that our support workers don't have a really valuable role, but it does mean that when we're looking at these important safety issues, that it's the registered nurse numbers that really count. And I think the other thing that really came out for me from the evidence, which has really stayed with me, is this whole issue about the relationship between safety and staffing numbers, and that it's not linear. It is not as straightforward. And again, this may seem obvious to people, but it's not as straightforward as the more staff you've got, the more safe you are. The fewer staff you've got, the less safe you are. And what this little chart tries to show is that one of the things that came out very clearly from the NICE work is that there's effectively a tipping point. So when you're relatively well staffed and you have high levels of quality and safety, taking staff, reducing your staffing levels doesn't actually, for the first at the higher levels, reducing your staffing levels doesn't have that big an impact on safety overall. But you get to a point where there's like a tipping point. And that when we looked at a range of studies, there is a tipping point in that relationship between staffing levels and safety, where suddenly it all becomes very serious indeed, and taking any hours out of that establishment or out of that shift has a dramatic and serious impact on staffing levels. And we tried quite hard to see if we could estimate where that tipping point was, and actually that was really difficult to do. I think we almost said that the much vaunted 1 in 8 ratio is kind of at or just beyond the tipping point in the great majority of cases, and of course in many higher dependency areas, then the tipping point is at a much lower ratio than that. But I think the point about that was getting people to have that tipping point concept in their mind, because that's one of the things that you all as workforce and nursing directors and other colleagues need to understand. Where is your tipping point? And helping people like matrons and ward managers to understand where their tipping point is, because the fact that these tipping points exist is really well evidenced. And so I think one of my reflections for all of this is that clearly we've got this guidance that's coming out from NHS Improvement, and you know, it's well written, and I'm sure you've all read it. It is worth going back to some of the evidence. It is worth going back to maybe some of the nice stuff, but also looking at some of the other published evidence around. Certainly, personally, I found the work of Peter Griffiths and Jane Ball in Southampton extremely helpful, particularly in their kind of meta-analyses of different studies. And of course, other nursing research is available, but it is worth, I think, taking the time to look at that. I think the final couple of bullet points here have really very much been touched on by Mark. But you know, what came across was that because the nature of the evidence is that what is safe will vary a lot on local conditions, the importance of judgment and use of judgment and understanding the basis on which you are using your judgment really came to the fore, and emphasising the importance therefore of process in setting standards. And of course that's now reflected in the NQB triangle approach in terms of making sure that you've got an evidence-based tool, that you are using professional judgment, and that you are looking at quality indicators. And I think the triangulation point is also well made and often made. I think the point I would want to make about that is how can we make sure that we aren't just using those triangulation that triangulation method in looking at annual plans or in looking even in our monthly board papers, but how can we help matrons and ward managers actually triangulate on a daily basis or on a real time basis, how they bring those different factors together. So that's where the concept of red flags came in, and people have taken that concept and run with it. I was very struck in the document, actually, the Sherwood Forest Hospital SOP for safe staffing, and the thresholds that they'd actually published within their organisation, which seemed to me to have something significant to offer. So those are just a few reflections on the work that, I'd say, was done 5 years ago, but much of which I think has been brought into the NQB and other work since then. So, and I'm going to change gear slightly and ask you to think a bit about where might boards be coming from. I appreciate most people in this room need to be involved in this work at an incredibly granular and often quite operational level. But what you also need to be able to do is help your boards make sense of all of this, and help your boards fulfill their own role. And I think it's very easy with boards to assume that they know what they want, they know what questions they want to ask, they know what data they want to see. And actually, they often need quite a lot of help in thinking that through. So Mark has touched on some of this, so I'll try not to repeat too much of what he said, but I think there are some issues in here that are worth working through. So I think the starting point really for boards is this whole question about how can we get at least a reasonably objective basis for setting establishments and for staffing levels on operational basis. And clearly you can think of those in terms of the potential poles of what a productivity, or if you like a Carter a requirement and approach might be, but also what a safety, a quality and a Francis requirement might be. What boards then need to do is they really need help in actually understanding what's important, being able to see the woods for the trees, and certainly I think when I've looked at board reports, including I think to an extent our own, it's very easy to present people with endless scorecards and tables and all the rest of it, and really actually pulling out for members of the board what's important and why is really significant. And I think that constant emphasis on your judgment is really significant. Clearly, there's a very, very important role around assurance in all of this, and I think that Mark and others talked about regulation, talked about the need for assurance, the single oversight framework, and how all of this is going to be brought into that. And clearly, that needs to be done in a sensible way, and be very focused on risks. And one of the things that Claire and Simon over there from MTW are bored of hearing me talk about when considering risk is the importance of thinking about not just what your risk is, but thinking separately about what are your controls and then what are your mitigations, and that differentiating between those two. So controls being things that you do to control the risk, to stop the risk materializing. And then mitigations being actions that you will take for those risks that do materialise, and trying to get people to separate those two things out. Very often people talk about mitigations or controls in a kind of rather loose way, and trying to separate out how you will prevent the risk from materialising from what you will do when risks do materialise, because some risks are going to materialise. I hope is quite a helpful way of thinking about it. But it seems to me that it's really important that boards go beyond their assurance function. And I know a lot of non-executive directors, you give them a wodge of papers and a load of graphs and they're away. And you've got 1,000 questions and it's all about how you make sure this never ever happens again, or, why is this ward 0.7 over something lower than this ward, and all the rest of it. And actually, I think one of the important takeaways for everybody here is to make sure that the work that you do for your board helps the board to go beyond assurance. How's the board going to use your staffing work actually to think about improvement? So what about all those green rated wards? How are we going to use any of these data to improve what we're doing for all of our patients and for the staff who work in those areas, rather than just only look at the reds? And I think a really important issue for me as well is, how do we use this information, these data, for engagement? And certainly an experience I think that we had in MTW was that when we went into financial special measures and inevitably we were having to look at a range of establishments, actually following the NQB logic was hugely important in engaging and generating confidence among the nursing profession across the organisation, and is something that we've then tried to replicate in reviews of other staffing groups as well. So those are some of the considerations I think for boards, and probably councils or governors as well, for those of you from FTs as well as for boards. What I'm now going to do is just share a little bit of what we're doing in MTW, but as I say, using that more to kind of prompt what have we actually achieved, but also where are we challenged, and what are we doing next. And I think what we do as a board would probably be very familiar to most of you. I think hopefully we're on the right side of Mark's audit over there in terms of what we do and don't look at on a monthly basis. But essentially we have an annual workforce plan, and then we have monthly reporting against a range of indicators, and we're using the Quest tool. We're reporting against care hours per patient day, and we're reporting the sensitive indicators. So there's some narrative out of which we pull actions and if you like, our worry ward list, as Mark was talking about earlier. But we also have a scorecard, and this is what our scorecard looks like. And again, I'm sure that you've all got something very, very similar to this, but essentially, we're picking out every ward, and we're identifying where we're at in terms of fill rate, where we're at in terms of care hours per patient day, the nurse sensitive indicators, the friends and family test, the Quest score, and also where we're at financially in relation to that ward. And as I say, I'm sure most, if not all of you, have got something very similar already up and running. I think the question is, what do we do with all these data? And what, if anything, have we actually changed? Again, going back to my kind of assurance challenge a little bit. Assurance is really important. I'm not suggesting for a minute that it's not. But actually, if we haven't changed anything as a result of all this blooming assurance, then we've kind of missed the point. So my last two slides just say something about some of the things I think we have been able to achieve locally, and then some of the questions. And then I want to try and get some examples from yourselves. So I think the first thing is, there's no doubt within our organisation we have now got, I think, pretty good triangulation with the nurse sensitive quality indicators between staffing levels at an operational level and the more sensitive quality indicators, and we can do that monthly, but we also use that in an operational way, and I think that's been the critical thing. That's what has enabled us to work with the board in terms of what should you read into this? I think we'll come on to this in a minute, but I think actually even with that quite limited data set, there are still some quite interesting questions about what do these data what do these data tell us? And the honest answer is we don't really know. So I don't know about anybody else in the room, but I think we think that the care hours per patient day and the model hospital stuff is great. It's really rich data source. We've yet really to use those data effectively to change our practice in a number of areas. And one of the bits bits of feedback I'd be really interested in is people who've used that, really just the model hospital and the CHPPD stuff, really to change what they're doing. but we have used some of these data sets to drive our thinking. We use the Quest tool to get underneath what's going on in those wards that we think may be in some kind of difficulty. And there's no doubt that Claire and her team have actually really driven action out as a result of some of these analyses. So, I've lifted there an example of revising our policy for assigning enhanced care. That was a direct product of Claire and her team going through that scorecard that I just showed you, and that wouldn't have happened without going through that approach. I referenced this a few minutes ago, but setting and reviewing establishments. I mentioned the fact that we had to do a big establishment review as part of being in financial special measures, and actually having a proper basis for doing that, and for justifying investment as well as areas where we could identify productivity opportunities was important, and that's now living in terms of these twice yearly reviews. So I think, again, I suspect this is true for many of you. I think we can now say that we've really embedded the NQB guidance in what we're doing, particularly for nursing and midwifery. I completely take Mark's challenge that we've a lot more to do to roll that out with other professions, and I think it is important that we've hardwired establishments with rosters and with the electronic staff record, as well as with expenditure, and pulling those 4 data sets together and really understanding the links between them, I think, has been hugely important. And then finally, clearly we are now using these approaches in terms of business planning, and that includes developments and budget setting, as well as looking at quality issues. So here are just some of the challenges that I think we particularly face at the moment. So CHPPD I've already mentioned. We think it's great. We think there's really rich data set. We think we've got a lot to learn about how to use it really effectively, and would be really interested in other people's experience of doing that. There are a whole range of new roles, and Mark's presentation particularly talked about these. In practice, how you reflect some of those new roles in these data is, again, quite a challenge. And as we move to more multidisciplinary working in our clinical areas, that's a specific challenge. And it's not just about multi-professional teams. It's actually about how do we apply this logic to other professions. And as I say, warts and all, I think we're much further down the road with nursing and midwifery than we are with most of our other clinical professions. And then finally, really being able to be sensitive around acuity and dependency in the range of settings that we've got is something that I guess it's one of those areas where you have to apply a lot of judgment, and that's an area where we're looking to develop. So those are some thoughts about kind of what I learned from doing the nice safe staffing work 4 or 5 years ago, some reflections on what boards might be after, and some of the both the achievements, but also the challenges of implementing this within an organisation like our own. So what I'd like to do now is really kind of throw this open to the floor, because I think it'd be really helpful to get your experience into this. And clearly, if anybody's got any questions about anything I've presented, I'd be more than happy to answer those. But I think it would be useful for you all to hear from one another. So I've got a couple of questions that I'd like you to think about, and then we'll open it out. And we've got roving mics so that we can play you in. So I think I've got 4 questions. The first is, what have you done that has generated confidence between board and ward? So what have you done over the last couple of years in this space that's really generated that confidence in either direction? Second question is, how have your safe staffing initiatives actually improved patient and staff experience? So not just demonstrated where you do and don't have good and bad patient and staff experience, but have you used these initiatives actually to improve things? My third question would be, what do you find most challenging in meeting your own or national requirements for safe staffing? And my fourth question is, what developments and opportunities are you exploring currently that you would like to share with the rest of the audience that you think will help you to address some of those challenges? Okay, so I think we've got, according to the programme, we've got about 10 minutes. So who wants to kick off? Who's got some experience they want to share, or some questions that they want to pose to the rest of the audience? Hi, there's a lady in the front here. Oh, sorry, would you mind just saying who you are and where you're from? It would be really helpful.
Thank you. Yes, my name is Lynn Andrews. I'm Director of Nursing at Chesterfield. Just one of the things that we shared at the board was we didn't really do a really good job where we closed one of the wards recently. It was a ward where patients went when they were medically stable, but it's part of our discharge processes. And we didn't do that in a particularly well way. And so we took the story to board, and both our staff partnerships were there as well as the clinical staff, and presented the cases between them. And I think that's a really powerful message to say this is where things haven't gone well and what we're going to do differently about it, and share the lessons that are learned. And that really engaged the board with clinical practice and the circumstances, which I thought was really good.
That's great to share that. And could you say anything about what you did learn? You know, what are you doing differently as a consequence of having been so honest about that?
Yeah, well, the QIA was one of the key things. Whilst it was in train, it hadn't gone through in a timely manner. So that was one of the things, was about doing that up front and being clearer. The other was around the timing of it.
Yeah.
And one of the issues there was about, while some of the staff knew, because it had been talked about as part of our plan, our strategic plans, that ongoing effective communication hadn't taken place. So when it came to the conversations that we're going to do it, and the timescales we did, which was quite short, that was quite a sort of different feel for the staff than what perhaps they had originally thought of and intended. So that was a very good one. And using staff partnership, our colleagues there as well, to support the discussions and the actions we were taking. These were all key things.
Brilliant. Thank you very much indeed. Thanks for sharing that. Who else has got some good practice? You've got to have some good practice. You can't have coffee until we've got some good practice out on the table. Who's got some good practice that they want to share, or something they're working on that they just think other people might be interested in? Right, so another lady here.
Sorry, you'll have to excuse me, I've got a bit of a sore throat. My name's Helen Judkins. I'm the Assistant Director of Nursing at the Luton and Dunstable Hospital. And it's really from what Mark said earlier on about assurance, and the worry wards. So how do we assure our board around our worry wards and about the metrics that you spoke about? So we developed a clinical leadership and development nurse 2.5 years ago. And the role is that Anne goes into a ward and works with staff to support them, and looking at the quality metrics, and gives a report to the board around how we can improve that with staffing, what needs to go in, have we got the skill mix right, what can we do differently. And I think our board have really realised that from ward level up to board level, it's really, really important that they understand those areas where we have challenges every day and we don't never always get it right. Somebody going in to guide and support makes a real difference. And I think even the non-execs have really enjoyed sort of hearing the stories about having turned wards around and giving people support to do that.
That's a really good example. Just before we put the microphone down, do you think it's worked in the other direction at all? So what have the nursing staff at close to the front line got out of you having that role?
I think, most nursing staff on the ward often feel that there is a bit of a disconnect from the board, and some of probably the senior nursing team as well. So I think they feel really that we really understand what's going on their area. And we've had some really good stories that we've shared across the organisation around, perhaps a leader sometimes that's new into post who can't turn around those really challenging staffing issues. And we recognise that sometimes we didn't get establishment right. So I think they really feel now that when this nurse goes on and does some work, it's not that they're a poor ward, because sometimes the metrics isn't too bad. It's just that we have that feeling that when we look at everything, that there's something not quite right there. And it's been a really, really good role, really good improvement. In fact, the nurse that embarked on this programme has recently done her master's degree, used that as her dissertation, and has won an award.
Great, okay, well, thank you very much.
Improvement.
That's great. So that was Luton and Dunstable. It was a really nice example. Okay. Go on, we've got a lady over here with a hand up.
Hi, I'm Chief Nurse at Royal Papworth Hospital, Josie Rudman, just to talk about care hours for Patient Day. We flipped that on its head about 8 years ago, looking at my colleague to my right. I think it was about 8 years ago, and we did a lot of work around articulating how many care hours each patient needs on the ward. So where you've got interpretation of care hours per patient day, we've done an awful lot of work around that, and we actually use care hours per patient day as a establishment tool, so we can it helps you articulate the registered nurse to patient ratio, the staff to patient ratio, and so not waiting for the NHSI figures to come back to you to tell you what your care hours per patient day should be. We can actually articulate each ward's average care hour per patient day.
That's fantastic. And if people looked at your website, do you think from your board papers or something like that they'd be able to work out, to get some idea of how you were doing that?
Yes.
Okay. No, brilliant. Okay, so that was Papworth. So again, if you maybe be the only person in the room who doesn't understand how to use CHPPD as an effective improvement tool, but there's definitely food for thought on Papworth. Right, we've got time probably for one more experience. So we've got we're going to take two actually, because I think we've got time for two. We've got a lady here and then one in the front row as well. And everybody on the left is going to have to be much more vocal in the next session, by the way. Right.
Hi, Suzanne Banks, Chief Nurse at Sherwood Forest.
Hi, Suzanne.
We developed the safe staffing
yeah.
safeguards. Just to say, actually, we've moved from doing it, so the work that we've done up to date has been collecting that manually, and we're now in the process of moving that to use e-rostering. So those who've got e-rostering, once we've got it slick, we'll be able to share that and people will be able to use it electronically.
So those thresholds that are published in the document, you're now building those into the ESR, the rostering tool, sorry.
Yeah, rostering.
Wow.
And so that literally with the intention is that by the flick of a button we'll get our position at any time in the day. So.
Fantastic. That would be great, and particularly I guess it's people are developing control rooms and all that kind of stuff around the place. It'd be really good to see that kind of information there. Okay, that's another take home for me. I can see Simon busy, furiously writing all these examples down. So yes, we'll have got good value for our train fares from MTW, I have to say, from you all. Right, we've got one more question here, and then I really am going to let you have a cup of coffee.
Hi, I'm Sam Foster, Chief Nurse in Oxford. So it's work in progress, this one. 12 months ago, we had quite a difficult CQC system-wide review that shared that relationships were fairly poor and patients weren't moving through the system. So over the course of the last year, we've been working really hard at how we review our stranded patients with health and social care colleagues, which I think has given us a much more of an evidence base about what patients are waiting for. We've employed a winter director who's got a fairly significant chunk of the pooled budget. And I think that the model hospital has shared lower quartile support workers in our trust and given us probably much more evidence around how we care for patients that are waiting. And we're certainly looking to share examples from other trusts about how they're caring for patients within hospital accommodation who don't need acute care, because we tend to rate all these patients as 1Bs. And I think we will probably not have a winter ward. That's certainly our aim, that we don't have one of those dreadful pop-up flex wards that gives poor care. So I think the stranded review and using model hospital data as a system will improve patient care for us.
Great. Okay, so that was an Oxford example, and definitely be interested in pursuing that personally. So, right, thank you all for bearing with us all. So I think it's now time for coffee.
Brilliant. Thank you very much, Miles. So coffee is available and tea at the end of the thing. So we've probably got about a 10 or 15 minute break before we go into the section on governance. Thank you very much. my people. Right. Thank you, everybody. It was short and sharp, but we'll get on with the finished part, the final part of the morning. We've got obviously presentation from my colleague Lorna, and then we've got a kind of panel discussion before we go into lunch. So there's plenty of opportunity to kind of network a little bit later on. So I hope you found the kind of morning sessions really helpful. Again, thank you very much to Miles for kind of his open and honest appraisal of some of the approaches and also the work that he's involved in. I think it really helps kind of frame it when one of our senior chief execs kind of talks about some of the kind of rational challenges that are within the system and how to kind of approach those. So thank you very much for doing those. The next speaker is Lorna Squires. She's head of the quality governance here at NHS Improvement, but has had a significant experience in leading quality governance and corporate governance within the provider sector, and there is a special place in heaven for this lady, because rarely, and her team member Becky, because rarely have I come across somebody who is so excited to look at board minutes and board governance structures and BAFs and goes through them forensically. But Lorna has got extensive experience in looking at what good looks like across the system in terms of involved in many organisations, right through from SOF 1 to SOF 4. So, you know, kind of her expertise being brought to this session, I think, is really valuable looking across the system. So thank you, Lorna, and I'll hand over to you.
Good afternoon. A nice dry governance session just before lunch. Thanks, Mark. So as Mark and Miles have covered quite a lot of this, and because there's diversity in the room, I will just turn the presentation off. So I thought we would start off with really understanding what governance is. So a lot of people bandy around the term governance and people get frightened. It's common sense, really. It's just a framework of systems and processes that allow organisations early insight into risks and issues so that they can resolve them in a timely manner. And they need to be supported by a clear accountability framework and a clear escalation framework, so everybody knows what they're responsible for and everybody knows what to raise and what to escalate. When you've got all of that in a row, you have effective governance, and effective governance then just gives boards the confidence to know that they are maintaining and continually improving services. No, wrong way. I'll get this right in a moment. We like to reinforce messages, so I thought I'd give you the national context in relation to governance. So we know that there has been a need to improve the governance, the robustness of governance around workforce since Francis, as we are all aware. But there have been more recent independent inquiries. So the most recent Kirkup independent inquiry into Liverpool Community Services, again, highlighted similar things and similar findings in relation to Francis. Through the CQC inspections and through the work that we do with organisations, we are still seeing that there is a lack of strong governance and oversight, and that's common particularly in challenge providers. As you are well aware, there is the backdrop of national workforce shortages, high vacancy rates and high agency, but there is still the statutory requirement to deliver high quality services within that constrained financial envelope that we are faced. And as we've heard, there is a need to focus and look differently at the way that we deliver care. And innovation in itself brings risks, and risks shouldn't be things that we're frightened of. And you should embrace innovation, but it should be done in a safe and controlled way, and that's where governance helps you. Again, as Emma pointed out, the guidance about what good looks like has been out there for many years, but we see significant change in the NHS, and we also know that we're not a very good organisation with a memory. And so what we have done with the Developing Safeguards guidance document is to try and bring back some of the key important things, particularly in relation to service changes and new roles, and remind you about what effective governance will look like in those instances. So I'm going to kind of focus on governance in two specific areas. The first and the main focus will be around the introduction of new roles and the need for quality impact assessments, so QIAs. I'm going to focus less so on business as usual because Mark and Miles have so articulately covered some of that, but I will touch on that and touch on some of the issues that we see. So there are some still live issues, as we've heard, in relation to how new roles are brought in, how service developments are brought into fruition, including some of the efficiencies around that. We are seeing workforce reprofiling and efficiencies still being agreed without a proper quality impact assessment, without clear links back to a contemporaneous workforce plan within that area, and without proper consideration and consultation with staff in those areas as to whether that's realistic or not. So there's quite often a top-down salami slice that says, okay, you've got to take 10% out, you've got to restructure your workforce to make some efficiencies. And so we're still seeing that done in isolation without a really robust understanding of what the potential impact on quality could be. We also know, because of the challenging environment that we're in, that the risk threshold is changing in organisations. So organisations' appetite to risk has to change as a consequence. So we have to deliver within the constraints that we currently have. So quality no longer trumps everything. It has to be a balance of operations, finance and quality. Well-led organisations manage the tensions well between the three. And so what we are seeing is that organisations really don't understand, particularly from the board upwards, their risk appetites. They don't understand the level of risk that they will accept in relation to patient safety. They don't really have a consistent view of the level of risk they will accept in relation to patient experience and staff experience, and they certainly really don't understand the appetite that they have to risk in relation to innovation, and the fact that they can be different and they can naturally be of different levels. So your tolerance to patient safety should be almost zero. Your tolerance to innovation could be significant. But the boards don't really embed that in practice or communicate that down to staff. And so you will have a look at your risk registers and you will have target risk scores. So you would have a target risk score for a patient safety issue that would be significant when your risk appetite is low. And therefore your target risk score should be comparable with your risk appetite. When you're looking at innovation, because potential risk to patient safety happens sometimes with innovation and new roles, you are seeing a risk target score of low, when actually you can tolerate a greater level of risk as long as you understand the potential impact and you are regularly monitoring and have clear oversight of those. We are also seeing those tensions, particularly in relation to risk appetite, play out in the board. And so you will hear in these afternoon sessions some real life examples of some of that. So you will have a strong and dominant finance director who says, actually, you have to take these risks because of the fact that we have to make savings. And then you will hear the clinical executives in the room saying, we will not tolerate those risks. You need to be clear as to what your risk thresholds are, because sometimes you will start to have to look at areas that you wouldn't have accepted in the past, as long as you've got robust identification of the potential risks, which we will go on and talk about in a moment, and that you are actively monitoring them as you're implementing those areas. So this is why we've needed to focus, again, on effective quality impact assessments. And so what good looks like is still linked to the original 2012 National Quality Board document. And although it talks about cost improvement plans, it is around service changes and any efficiencies or reprofiling that you may want to do. So the language might be historical, but the practice is the right thing. As we've heard, the key to this is engagement, 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 engagement. And I will go on and talk about engagement a bit more. But it isn't consultation post the event. It's engagement with clinicians at the beginning, at the infancy, at the creation of the schemes. There needs to be a clear framework around those schemes. So we heard earlier about the fact that QIAs had been done, but the scheme was being implemented and no one really understood what the QIA was. Actually, you should have a gateway process where schemes aren't starting to be implemented until the QIA is signed off and is communicated. You do need to listen to the staff, and you need to modify the schemes in relation to their concerns. What we often see going into organisations is schemes have been implemented, new roles have been implemented without full consultation, and you've had to reverse them. So after 6 months, you've had to reverse and start again, and then you start to talk to staff. If you start to talk to staff at the very beginning, you are going to avoid those pitfalls. Again, you do need to ensure that you know what it is that you are measuring. And so Miles gave a very good example of where you are looking at staffing against the proxy quality measures. So when you are looking at early warning indicators, they need to be sensitive enough to reflect the schemes in which you are developing or the new roles in which you're looking in, and not necessarily just using the proxy quality indicators because they may not be sensitive enough. Or if you are just using the proxy quality measures like pressure ulcers, falls, you do need to be able to have a clear process of deep dives where you are seeing targets going off. You need to understand whether new roles, new schemes, different workforce profiles is actually having that impact. And there needs to be clear board visibility. And the board does need to have the details of the granularities of teams and wards. And quite often what we do and what we see when we engage with organisations is the board only wanting to see an aggregate position. And that's not true. The board needs to understand its worry wards, understand its worry teams, and understand the services under pressure. They don't have to get into the detail of the nitty-gritty of how you're going to resolve that, but there needs to be clear escalation and visibility of those issues. I did say I was going to talk about engagement. The evidence is there. So Virginia Mason are seen as lean, sometimes perceived to be just efficiencies. But actually their model is engagement at all levels, all of the time. Bullet points 3 and 5 are the main drivers why you really do need to engage with staff. When you are looking at changing the way that you are working, if you have early engagement, the clinicians will own it and therefore are more likely to deliver it successfully. When you are looking at care that goes across traditional professional bureaucracies, traditional professional boundaries, if you have clinical champions driving that message, so if you have a medic driving and standing shoulder to shoulder with the ACP nursing lead about a new model of care, they are likely to be able to sell the model more successfully than the manager in that area. So clinical voices are powerful for proper delivery and sustainability, but also acceptance of new ways of working and innovation. So your QIA process, your risk assessment and your structure around new roles, what does that really look like? More often than not, there is a PMO in place to do the analytics, to do the reporting, to save you the time to collate all of that information. There is a gateway approach, and you go through that gateway approach with rigour. So you create the ideas, you detail what that will look like, what that will involve, and how you are going to mitigate any risks that are potentially linked to that. And then you will have that signed off, and that sign-off needs to be with the clinical executive directors, with the nurse director and medical director. And there is clear and ongoing monitoring of those processes. And we're going to talk a little bit more about some of the common pitfalls with monitoring, linking back to something that Mark raised earlier. And again, it needs to be locally owned. So you do need to start all of this from the bottom up. And actually, you need to have a mechanism for challenge across directorates or care groups, because care may be delivered across your clinical business structures. And so if you have a star chamber or a clinical senate where all of the clinicians involved in a particular pathway are in the room, then they are better able to understand and foresee potential risks than if it is created in a silo divisional management structure. And then it does need to link through to the organisation's risk appetite and the organisation's risk management processes, and link through to your risk registers. So any risks that are live need to be recorded on your risk registers. It's quite often where the CQC will come in and clearly identify straight away that there is a disconnect between the frontline staff and the board, linked through to local intelligence and local risks not being on the risk register. And the same goes with new roles. So we heard earlier about a CQC interview about really understanding the risk involved in implementing a new role. So the CQC are very linked into all of this. They are now paying attention to risk registers and governance as an important mechanism in organisations. And it needs to come all the way up to the board. So learning again from Francis, it doesn't sit at a local management level. The board does need to have visibility of some of the granular information. So what we have put in the appendices is kind of the general principles of what a quality impact assessment really should cover. And I will go through some of the reasons why. We quite often see that you aren't considering all of the potential areas of impact on quality. So the CQC constitutional standards kind of get mixed. We're very good at looking at patient safety. We're not so good at looking at the effectiveness side, the outcomes, and the staff experience. So we quite often see quality impact assessments that just have the DASI domains of quality and don't look at staff experience. So we need to really understand the impact on staff as well as the impact on patient. And it needs to be linked through to your risk management processes. It shouldn't be in isolation. It should be part and parcel of your main governance processes. And it needs to be all foreseeable risks. And so some of the things that we're seeing with new roles is that actually the risk assessment in relation to the potential impact of the delivery of that new role or how you will successfully implement that new role is missing. So you are quite often putting new roles into areas that have vacancy challenges and are really busy, ED being a classic example. When you're putting in a new role, they will need enhanced supervision and training. Some of the new roles, if you're looking at ACPs, will need medical supervision. Look at the GMC trainee survey in relation to how those staff currently in post really experience their supervision. So quite often we see missing is a real understanding of what the potential implications of the demands of enhanced supervision and training in that area are on the existing workforce to be able to really safely deploy the new model. The same goes on wards. If you are enhancing practice, so a band 5 is acting up into a different role, what is the impact that that's having on the staff underneath? Are they having to step up to higher roles to cover the gap? And so when you're looking at new roles, these are all foreseeable areas that we quite often see missing in quality impact assessments. Once you have a comprehensive QIA, then you need to agree it through your regular processes. I won't labour on some of this because I think we've discussed this. We will talk a bit more about this in relation to business as usual. But it needs to be locally owned. You should see it through your strategic workforce committee or equivalent in your own organisation, and there should be consultation with your staff side, and if you have any professional staffing groups that already exist through that. And then obviously the board needs to see sight of that. So echoing a lot of the messages that we've already heard today, some of the common pitfalls that we see. So we are still seeing at the end of the year budget reviews and removal of posts that have been vacant for up to 12 months. Sometimes they're with a risk assessment, other times they're not. So they should never be done in relation to, without any consideration to a quality impact assessment, a real understanding of what taking that post out. But also linking back to Mark's quadrant, where he was identifying the wards that were under the staffing establishment was still delivering on outcomes. So was that the bottom left? Is that the bottom left? So, you know, really good outcomes in the bottom left. But that's at that period of time. Now, we know through reports like Kirkup and the Francis inquiry that staff will generate and hold on to a significant amount of pressure for 12 to 18 months. And it's not until after that that you start to see those pressures transfer into deterioration in quality of care or high turnover rates, and they will enter into the top left quadrant from being in the bottom left quadrant. And so you need to make sure that it's not at that point in time that you really understand when you're taking out a post how long they've been out. You need to understand the staff's views on what that currently means in relation to their current pressures, but you also need to think about what you need to closely monitor moving forward to make sure that in 12 months' time, in 18 months' time, you are not entering into a ward that would then be challenged with high turnover and poor patient experience. So complaints are always normally a very early indication of where dissatisfaction occurs. The staff will behave, their attitudes will change, and the patients will feel it earlier than you will see that really indicating in the proxy quality measures. So you need to be very careful that when you are taking out at the end of the year that you are considering the future potential impact and how you will monitor that. And we're still seeing that the risk assessments are going, there's no risks as it's fine at the moment, but actually we could quite easily move from the bottom left to the top left in 6 to 12 months' time. So this is an organisation that I've worked with. Forensically, because I'm a bit like that, analysing their board reports, observing their boards, and buried in all of the board papers. One was in the workforce report, and one was in the CQC action plan, their quality improvement plan. So Trust A was talking about the fact that actually we're going to reprofile and reduce our midwifery staff. Hadn't considered birth rate plus, hadn't really considered where we were, but it was their turn because Children's had taken some money and savings out last time, and the clinical support services had been squeezed beyond belief. So it was women's services turn to take money out of their areas. And in the same board reports was the outcome of their recent CQC inspection, which highlighted insufficient staffing in relation to midwifery. And so this was last year, but we are still seeing this. We are still seeing a disconnect and a lack of triangulation at a local and board level of the intelligence there. And you are reprofiling your workforce without really looking and understanding what the current challenges are. So other issues that we currently see, the bold ones are probably the most difficult. As we've talked about, the quality impact assessment lacks depth and foreseeable risk. And that's linked to the fact that also to save time and pressure on the nurse director and medical director, they don't see all schemes, and they only see schemes that are above a threshold of £50,000 or a risk score of about 9. But when we're seeing the risk scores not being done well and the foreseeable risks not being scored, there's a real danger there that the right information is not getting to board members at the right time. And it's about that joined up cumulative impact. So taking out and reprofiling one or two roles over time, or actually taking out one in different areas but they have an impact across the same pathway, but they may sit within different clinical business units, which is why you need to have a holistic view of what's going on. There is consistently a lack of soft intelligence to really enhance the understanding of what's really going on in those areas when you are looking at staffing challenges and how you would effectively safeguard that workforce. And we are still seeing the reversal of schemes 6 to 12 months down the line because there hasn't been adequate consultation and engagement with frontline staff. Save yourself time. Talk to them at the beginning. They know what's going on. They'll tell you. It might not be comfortable. There may be a discussion about balance of risks and having to take some risks, but you make sure that you monitor it on a regular basis so that you can see when it does start to bite, if it does start to bite. And what we see is those decisions are made by executive directors and not the broader board. So this links back to business as usual and the role of the unitary board and the role of the non-exec director. So quite often the information is held through the performance management meetings or the executive management team and not through the assurance route. And so the non-exec directors who are there to hold the exec directors to account do not see and haven't got clear sight of what's really going on. Which brings me to business as usual governance. I think Mark and Mars have very clearly articulated what good looks like in some of these areas. So I would just quickly skim through some of this. So it is about ensuring, as a board, you are making sure that the NQB guidance is there, that you've got the right skills in the right place at the right time, pretty much, and you use your governance structures to highlight when that's not there. And so it is through daily processes through to yearly processes. So you would expect, and we know that is well embedded in relation to nursing, daily escalation of where you have tensions so that they can be resolved. And you would hope to link that through to your normal governance processes like incident reporting. We heard about the need for a holistic understanding of performance. And so quite often we see, particularly when the board delegates its responsibility down to the board committees. So you were hearing earlier about the Quality Governance Committee and the Finance and Performance Committee. The Quality Committee would see the quality metrics, the Finance and Performance Committee would see the finance aspect and probably the performance standards. Where does workforce sit? Where does the retention and recruitment and turnover rates sit? Where does the staff experience sit? Is your quality looking at staff as well? Is your finance and performance also looking at workforce? One of those committees should have a holistic responsibility for overall performance. That doesn't mean that they have to do all of the business. The quality aspects of that can still be done by the quality committee, but one of your board committees must have a holistic overview of your performance. The board, quite often, unless you're a very small organisation, the board doesn't have time to be the only place where a holistic view of the world is there. And so it is recommended that one of your board committees does actually have a holistic overview. So that you can identify the tensions. Obviously, you should be seeing an integrated report coming to your quality committee and through to your board. There needs to be a granular cut down the organisation so it is easy to feed up. And then obviously you've got your 6-monthly acuity and dependency and you've got your annual workforce planning. This we talked about earlier. The pitfalls in reality tend to be on the left-hand side as you're looking at it. So we see still information being held at the division and care group level. There needs to be a clear escalation framework in organisations to ensure that that intelligence comes both through the performance meetings through to the executive management team, but more importantly, that your board committees have oversight of those issues. And it does link back to the board's responsibility so that the non-exec directors who chair your board committees are able to do the job that is devolved down to them so that they have clear oversight of performance so that they can hold the board to account. You do need to make sure that the data is triangulated. And then we get into my favourite topic, which I will stand off of my soapbox today. But we are currently seeing, both at board committee and at boards, reassurance, not assurance. You have and are clinical, credible clinicians in your own rights. You are industrious and you have delivered results. Therefore, when you stand at the board and give a verbal update, I'm providing assurance. Well, you're not. And actually, it always comes back to bite you. It might not be today, it might not be tomorrow, but in 12 months' time, believe me, it will come back at some point. And so it is about evidencing through effective reporting, as Miles has articulated, rather than a verbal assurance that you have gone to that ward and know it's safe. You have visited that team and it wouldn't happen on your watch. It does. Particularly where there is a disconnect between what the frontline staff are seeing, what you see on that day, and the reality of day-to-day working life looks like. We are a risky organisation. You know, day-to-day it's going to change. Risk is always going to be there, and therefore it just needs to be visible and managed. So you need to evidence that there are risks, that you are in charge of them, that you are doing something to resolve them, and these are the outcomes that you will look to prove that those risks have been resolved. And the kind of purpose of today is that if you know that you've got issues in your areas, there is going to be increased scrutiny from the external world to you as providers in these areas. So this is your opportunity to raise with us some of the areas that you would like further support in, or we will come in and help you. And so please, either through contacting us directly or coming up and talking to us or raising questions through the panel, please kind of talk to us today about some of the issues that you're currently facing that you know you've seen through the presentations today. Thank you.
Brilliant. Thank you. Really conscious of time, and we've got to get down to don't go anywhere, Lorna. The questions. Really conscious of time in terms of getting down to stairs and back up again. So I'm just wondering whether or not, because I heard kind of a lot of questions being discussed in the audience, whether you have any questions for Lorna we can talk through now. What we might do is perhaps not do the panel just in terms of time, but obviously for some detailed questions. I know that Miles is around, myself and Emma are around, so if you wanted to contact us through lunch, more than happy to answer any specific questions. But I'd just like to say a massive thank you, because I know those slides come at a huge amount of travel across the country working with boards and presented back in a really, really kind of easy way to kind of understand, particularly in terms of experience. So I'd probably like to open it up for Lorna to answer any questions. No. Please, after Lorna.
Carry on.
So, my organisation is baked in the CIP and budget set at the beginning of the year. So we find ourselves having we're now doing a retrospective QIA of budget setting in Q3, which doesn't feel comfortable.
No, and so your processes should be dynamic. So you should have kind of quarterly reviews where your systems are set up so that you can, when things change. So, and it's not just budget setting, it's also, what I didn't say, is your vacancy panels as well. So you do need to be mindful of your vacancy panels also linking into the risk assessments. So you might want to consider not a one-stop shop at the beginning of the year, because actually it should link through to your day-to-day business as usual processes. So as things change, you should, so if you're not delivering, you need to bring on new schemes and they need to go through the gateway. So this is where you have a gateway process that's dynamic through the year and that you can have quarterly check-ins. So where was I recently? There is an organisation that has quarterly check-ins. I think it might have been Imperial. Is anyone from Imperial in the room? I can find out for you. Your processes shouldn't be affixed at the end of business planning. They should now be dynamic and normally have a quarterly check-in.
Thank you. Further questions for Lorna? Gentleman back.
Hi, I was going to ask if you've come across any processes around QIA for things where you're actually not taking stuff away. So I think CIP I'm fairly comfortable, but some of the things around additionality, whether that's winter surge or whether it's new business or whatever, they often carry the biggest risks.
Yeah, and so the same principles apply. So you are basically doing a risk assessment. So whether that be delivering care in a different way, whether that be delivering care over a different pathway, or that be putting temporary resource in, how you're going to staff it, how you upskill those staff, what the potential quality issues are in having that temporary resource, and how you will safely manage that and take it away at the end of the year. So I don't think that there is a need for anything different, because I think what you need to do is just do the risk assessment in relation to those component parts.
Thank you. Time for perhaps one more question. No. Brilliant. If we can all thank Lorna once again for a really helpful presentation. So thank you very much indeed. No, really great session there. Thank you, Lorna, because like I say, it's something that actually highlights there's some gaps, but actually there's some areas doing really well in this kind of area, which all formulates part of what we're trying to achieve here in terms of the day session around workforce safeguard. So I'd just like to say a huge thank you to the speakers this morning, Emma, Miles and Lorna, for setting up the day. This afternoon we've actually got a kind of slight shift in emphasis, and we kind of look at some of the particular challenges in those organisations that have been actively managing challenges in this space. And so I'm really looking forward to the two sessions this afternoon from Michelle and Helene. So I'd just like to say thank you once again. Obviously lunch is downstairs in the main restaurant. We've got approximately about 50 minutes for lunch. So if people could be back here promptly at around about 1:25, ready for our start at 1:30, that will be great. We will absolutely get you home on time. I appreciate you've got long distances to travel, so we do aim to finish around about 3:45. I'll kind of wrap it up quite quickly so you can get away. So once again, thank you very much for your time this morning, and we'll look back for you in the second session this afternoon. so grateful to Michelle and her kind of heartfelt testimony to you today about how kind of sometimes tough these things are, and I'm just really grateful she's been able to share that kind of experience with you, you know, in terms of warts and all, in terms of some of the challenges they face. But I think importantly, I think what you have seen here is a kind of leader who's prepared to kind of face up to some of those significant challenges, engage the front line, and actually, you know, work through the plans. And we've learned a lot, as much as Michelle's learned a lot from us. We've learned a lot around developing workforce safeguards, you know, from their experiences of an organisation in terms of making the changes and the challenges that they have. So I'm really personally grateful for your talk today, Michelle. Well done. You said you were nervous, but I think you nailed it. Yeah, she was brilliant. So I say really massive thank you to her. Our final speaker this afternoon, before we move into a panel discussion, and it's a real pleasure to invite Helene Donnelly to join us in terms of the conversation. Some of you may know Helene Donnelly from her work. Helene used to work at Mid Staffordshire, worked there for many years, and was one of the first people to identify some of the most significant challenges of that organisation, and became her mission to try and raise those concerns and deal with it. It was awarded an OBE for her services towards nursing and to the NHS as a result of having significant resilience, really, in terms of making sure that an organisation was trying to do the right thing. So some of you may have heard Helene speak before, but she's now in a new role, working as an ambassador in an organisation here in the Midlands, and it's a real pleasure to invite her to talk about her kind of experience, really, the consequences of you know, decision making and what they mean to the kind of frontline staff and her personal. So Helene, a really warm welcome, and thank you very much for your time today.
Thank you, Mark. Hello, everybody. So Mark's asked me here today to talk to you about the sort of human consequences of when we get workforce decisions wrong. And as he said, my background really lies within mid-staffs and the very real human failures there. And then, as Mark said as well, what I've gone on to do since then, and hopefully help try and drive some cultural change throughout the NHS in terms of ensuring that staff can speak up when things are not right, because we know they're not always right. So again, if some of you may have heard me speak before, so apologies for that, but I will talk a little bit about my own personal experience in mid-staffs, because it just, I think, helps put it into context. And I think also all of us now know the ramifications of mid-staffs and the Francis report, but not necessarily everybody knows that real human impact, and not just on the patients, but crucially on the staff before we even got to patients. And that's my kind of take-home message today, really. It's about looking after the staff, because if we don't look after the staff, they can't look after the patients. And I think when I started the work I do now, I kind of knew that, but I was still very much, you know, nurse hat on, very much patient-focused and patient outcome delivery kind of focused, and it's very much become a real impact on me, just how badly in some instances we care for our staff in the NHS, and the impact of that on patients. So that really is the key message. So my experience is as a relatively junior nurse. I was a newly qualified nurse when I first started working at Mid-Staff, so I'd trained elsewhere, which was great because it afforded me a bit of experience and insight into how things were done elsewhere. But because I lived in Stafford and it was convenient, and I was sick of doing sort of back-to-back shifts and travelling and so on, and a development rotation came up, which was fantastic. So I knew I wanted to do sort of emergency care, intensive care kind of work, but I didn't know exactly where. So that's the rotation I went on. And I had a really good experience. It was a sort of 6-month rotation, and the first 2 wards and units I worked on, so I worked on a general medical, respiratory cardiac ward, but quite acute, and then went into the acute cardiac unit, which was fantastic. Really great care, excellent, dedicated staff, really well run and well organised. Then I went to work on a medical assessment unit through ITU as well, and had relatively good experiences through that. But it was only really when I ended up in A&E that I sort of immediately started to think things aren't quite right here. But again, as a junior person, it's very difficult for you to sort of immediately come in and start saying, well, this isn't right and that doesn't look right. But at the same time, those kind of fresh eyes of coming in afford you that insight really into thinking, hang on, this doesn't look right. So you're in a really difficult position. But it soon became clear that others felt the same. I wasn't on my own. Other staff who'd been there for quite a long time, some of them felt that things were not right. So I started doing what we were always told to do, so incident report, speak to your line manager, and this had no impact. We weren't given no feedback to the incident reports at all. I was later told, particularly back then, they were just the handwritten copies, I was later reliably informed that they ended up in the waste paper basket of the line manager. And we didn't get any feedback from line managers or the senior managers. So it became sort of, you began to sort of lose hope and become quite apathetic, really. But this also coincided with sort of a perfect storm of events. So we had a line manager who had been there for a long, long, long time, and to some extent, some of the failures had occurred and begun on her watch, but she did offer some leadership. So she retired and wasn't replaced for quite a long time, best part of a year, and so we were left without any formal nursing leadership or any ward manager. And two nursing sisters who had been in the department for also a very long time sort of unofficially rose to the fore and started unofficially leading the department. At the same time, the medical director of A&E, medical lead, died very suddenly and very tragically, and he wasn't replaced either. So we now had no leadership, be it nursing or medical. We were massively short of staff, both nursing and medical. Short of equipment, basics like pillows, blankets, you know, really simple things, but mean a huge amount to patients who are in pain and in discomfort. And we were then told that we were not allowed to have bank staff. We had to use our existing staff to come back in and do extra shifts, so everybody was already working over and exhausted and coming back in. We were relying heavily on locum medical staff, which again isn't reliable, and you don't sort of get the rapport you need. And we were told as well that we were not allowed to have any training and development. That was all cut. So all these things started to really create a really unhealthy and quite a toxic picture. And then it was made worse again by the fact that the trust was deciding that it was going for foundation status. And that was the real sort of nail in the coffin, as it were, because that was the driver then. It was absolutely all about hitting that foundation status, being in charge of our own finances. So that's why the financial elements were just so important. And they were absolutely cutting down on everything. But we were told throughout all of this, as we still raised concerns, that just hang with us. You know, they were sort of dangling the carrot of, it's going to be better because we're going to get foundation status and then it's going to be fine. We're going to have loads more nurses, loads more doctors, all the training you want. It's going to be great. It's just this period. You've just got to keep with us. And of course you do. You want to. You know, you want to be a team player. You want to sort of, you know, see the light at the end of the tunnel. So you think, okay, we can do this. They then started to modify and change the department, so obviously a lot of costs went into that. So that caused a lot of logistical nightmares in terms of how we ran an A&E effectively. And that in itself has caused a lot of problems. So we're continuing to raise concerns through that process as well, and really just felt that we were not being listened to. So at this point they created a clinical decisions unit. So the other massive driving factor was had foundation status, but we also had the 4-hour A&E wait and the breach time of that. So that was the sole focus of everybody in the hospital, was getting people in and out and through A&E within that 4 hours. And of course it wasn't possible, not just because we had issues within A&E, but we didn't have the flow through the hospital, as I'm sure you can all appreciate. So for very real reasons, we were not hitting that target. But the pressure that came down from above, the wrath that befell any of us who didn't hit that target was immense and really unjust and unhelpful. So it developed a situation where those in charge of the shifts in A&E started to falsify, lie, pressurise others to amend the 4-hour time on the patient's documents so that it looked like they had left within 4 hours when indeed they hadn't. And in some instances, they hadn't even been seen in that time. They hadn't even been initially assessed. Let alone any sort of decision being made. So that in itself was a concern we were raising. So they created this clinical decisions unit. And it was just that, to await a clinical decision, be it admission or discharge, so they could go home. But there was a very, very clear and detailed operating policy that was established, and almost immediately this was not adhered to. So there were things like the patient had to have been seen and assessed initially in A&E before being moved to this unit. The patient had to be reasonable sound mind. They couldn't be left if they were vulnerable, if they had any mental health problem. We've been moved out within 24 hours. But as I say, this was all not adhered to on day one. We had lots of factors. Although they might be in there waiting for X-ray, bloods, that kind of thing, they wouldn't necessarily get any further on with that and any appropriate other investigations ordered. So again, a whole kind of gamut of reasons why this wasn't appropriate. And the other reason it wasn't appropriate was because it didn't really solve the problem in any way. The unit was basically just an old A&E theatre that they just fitted out with 4 beds in. Had no natural light, it had no appropriate toilet facilities at all. It literally had one tiny little cubicle with a basin, so no disabled toileting facilities. And again, we didn't have meals in A&E, and it was the A&E staff who were tasked to staff and observe this unit. So we had no additional support or help to do that, and we were already overrun and overstretched, so it served no real purpose. And it was down a very long corridor, quite away from the main hub of the A&E unit, particularly when this changed again when we had the refurb. So again, this caused major problems, and we'd often have patients or relatives sort of wandering down the corridors just trying to find somebody to look after their mum or their relative, or could they have a glass, or could they have a blanket, or could they have a commode. And frequently find patients who had soiled themselves in their own sheets because they were calling and nobody was there and nobody could hear them. I remember one gentleman trying to find somebody to help his mum, and he came sort of into the nurse's station and asked for some help. So I explained to him this, we would be with him as soon as we could, and he said, well, I don't understand, because we saw you yesterday, you're A&E. My mum's in the clinical decision unit now. I said, yes, but it's still technically within us, it's still A&E. So and he said, but I don't understand that, and she's supposed to have been discharged from A&E because she's been here for days now. And so I had to explain to him, but he couldn't make any sense of it, and to be honest, nor could I. So I would encourage him to put in a patient complaint. But you know, this was just not enough for me. I just thought that every day I was just going in and sort of sticking a band-aid on the problems and going home thinking, you know, this isn't why I came to nursing, this isn't what I wanted to do. So things got worse and worse, and the 2 sisters who I mentioned were particularly bullying nurses and doctors into falsifying the breach time, and if you didn't do what they wanted you to do, your life was made very, very difficult. A lot of junior doctors who were just on rotation would, particularly in the absence of any clinical medical leadership, would defer to the senior sisters' knowledge and direction and say, well, okay. And they would be intimidated and manipulated into discharging patients before they'd had the correct bloods back or before they'd even assessed them properly. And one particular occasion sticks in my mind, and I think was probably one of the turning points for me. I mean, I say probably because there were many, but this is one of the biggest. So I'm going to apologise if I get upset, because I generally do when I tell this story, and I don't know why, because it's been so long ago and I've told it so many times, but every time I relive it, it does do that, so I apologise in advance. So it was particularly busy, well, they were always busy, late shifts, and I was in recess, as I usually was. And we had a patient who'd been waiting for some time. I'd passed her several times in a long line of patients in the corridor with a paramedic waiting to come in. And eventually she was brought through and placed in a cubicle, but still in her wheelchair, and paramedic had gone. So I was rushing through into the resus, and one of the junior doctors called me and said, could you give me a hand? I've got this patient I need to see and assess, but I can't get her out of her wheelchair. So I said, yeah, okay, I'll be with you in a minute. So I went through and saw the patient I'd seen earlier, and tried to manoeuvre her out of the chair, but I was not going to do it on my own. So I said, hang on, I'll just go and find somebody to give us a hand. So I went to find somebody, and the only person I could find was one of the sisters I've mentioned. And she sort of reluctantly came, and as soon as we went through the cubicle, she took one look at this patient, obviously recognised her, and said, oh, God, it's just you again. Then she looked at the doctor and said, oh, you don't need to worry about this one. don't bother getting her out of a chair. You don't need to examine her. And he said, well, she's come in with abdominal pain, so I want to do an abdo assessment. And she said, no, you don't need to. She was in yesterday, and she's just a naughty little monkey. And she's just constipated, and she's not taking her laxatives. Don't bother getting her out. We need the space. Just get her discharged, get her back home. She can go back to the nursing home. So the backstory to this is that she was about 75, so not particularly old, and had been in good health really, but it's very suddenly in recent weeks sort of gone off her legs and become a little bit infirm and unwell. So she'd gone into a local nursing home just for respite only. And she didn't have any relatives or friends nearby, I think, so she was quite vulnerable. And she had started to feel that she'd got abdominal pain and so on. So she'd come in the day before and had been diagnosed with constipation, basically, and given the relative laxatives. And then at this point, so the sister's sort of speaking to the doctor and the patient can obviously hear, and I noticed that she's crying. So I bent down next to her. Sorry, I told you I would. And just, tried to just reassure her, and she was so apologetic. I'm sorry to be a nuisance, Duck, I'm so sorry. And she said, I haven't been taking them because I can't get out my chair at the home to get to the toilet, and I'm so worried about soiling myself. That's why I haven't taken them. But I know I'm naughty and I should have done. So I said, don't worry, we'll sort you out. So the sister had gone by this point, and the doctor had given his instructions. But I said, look, come on, let's try again, we can get her up. So as we're trying to then get her up and get her out onto the trolley, we get a standby call and I'm called back up into resus. So I said, look, I'll be back, or I'll try and get somebody else to come to you. So I go off, I've managed to find a healthcare support worker and said, please, can you go and help? Which apparently they did try to, but they were called off as well. So I go into resus and I'm there for some time. And I come out and sort of want to know, I go and she's not in the cubicle she was, so I know she's disappeared somewhere. And eventually I find her in the sort of makeshift waiting room, just sitting on her own with a wheelchair. And she started vomiting into a bowl. And I go and find the doctor again to say, what's happening with that lady? Did you examine her? And he said, well, no, because I was never able to get her out the chair, and the sister moved her out into the waiting room, and they've booked an ambulance to take her back, so I've just discharged her. So I said, well, she's now vomiting, so I think you need to reassess her. And he said, well, I can't because she'll be coming up to a breach now. I said, well, forget a breach, we'll book her in again if necessary. But again, I get called off into resus, so I can't do much more at that point. Except I did go and speak to the sister and reiterate my concerns about it, but again, I was in resus, so I couldn't do much more. So the next morning, I'm on an early shift again, and we get a standby call, I'm in resus again, and the paramedics arrive, and this patient's now on a trolley and coming back in to resus, and she's sort of in and out of consciousness, but she recognises me at this point. Again, getting upset. And I took my hand, I took her hand, and she said, am I going to die? And I said, obviously the best thing, all you can say at that point, just try to give her enough reassurance I could at that point. And ultimately she did die. So my upset about all of that really was the fact, not necessarily that she died, because a post-mortem and further investigation proved that even if she had been admitted, it wouldn't necessarily have made a difference. I mean, I thought she'd got some sort of perforation or something like that, which she didn't. But that wasn't really my argument necessarily. My argument was how badly she was treated in her last 24 hours of life. And it was compounded and made worse by the fact that when I'd found her sitting in a wheelchair vomiting into a bowl, it was about 6 o'clock in the evening. I later found out that she waited till 1 o'clock that morning, the next morning, before a non-emergency ambulance was available to take her back to her home. And she was left all on her own in a chair for all that amount of time, only to go back to a nursing home, to come back in again in a much worse state and to die in those circumstances. So that for me was a crunch point of, look, we just can't do this anymore. This attitude, this behaviour towards our patients as if they're a nuisance is just not right. So I started to escalate more and more concerns, and particularly around the behaviour of the two nurses I've mentioned. And that's just one example, there are many. So there were some action taken initially, and we ended up with an investigation, and we ended up with 2 nurses being suspended, but the investigation was flawed from the outset. The investigating officer tasked to look into it initially was well known to be very good friends with 2 nurses in the hospital, so that didn't really help or fill us with any confidence. We then did have an independent investigator who came in. I went to my meeting for about 3 hours, came back. They eventually sent me through the sort of transcript with HR from that meeting, and there was some inaccuracies, so I sent it back saying, if you can just amend these bits, I'd be happy to sign. I never saw it again. The sisters were suspended for probably about 6 months, if not more, in total, and we still didn't have a conclusion to anything. And the staff were understandably quite concerned, but by this point we had had a ward manager appointed, a permanent ward manager appointed. So on one particular day, we were all taking it in turn to do our off duties, and it was my time to do it. So I'd gone into the staff room to take down the list of people's requests for off duty, and our ward manager, who'd I think only been in post about 2 weeks at that point, to be fair, but came up to me and said, "Oh, by the way, Helen, before you take that down, you need to factor these 2 back in," and pointed to the 2 sisters' names. And I said, "What do you mean?" And she said, "Well, they're coming back next month, so you need to put them back in." And I said, "What? What do you mean they're coming back? We haven't had a conclusion to the investigation or anything." So she said, "Well, I don't know, that's all I've been told, you just need to do that." So I was very bemused and confused and went out onto the shop floor, and one of the matrons, who had been very supportive through the process of raising our concerns, came to find me, and she looked quite ashen, and she said she'd just come from a meeting and just heard herself that they were both coming back. And she herself had raised the fact that there'd been no conclusion to the investigation, and what support was there going to be for the staff who had spoken up and so on. And she was told in no uncertain terms by the Chief Operating Officer to sit down and shut up, that the decision had been made and everybody had to get on with it, and that was that. So the matron's advice to me was, "You need to get out." She said, "I'm going to leave, and you need to do the same." So I was like, okay, that's great. So around this point as well, I should mention that when we'd sort of had the investigation start and we'd been going to interviews and so on, I did think, well, I probably ought to get a bit of advice from my union, because, again, at no point when I was sort of officially putting in reports and so on did I think I was blowing the whistle or anything like that. I just thought I was just doing what you're supposed to do when things are not right as a registered nurse, but just as a human being, to speak up and say this isn't right. So when it all escalated like it did, it shocked me a little bit, and I thought, oh, well, I probably ought to sort of get some advice. So I went to speak to a regional union rep. I purposely didn't speak to the local reps within the hospital because, again, it's a relatively small hospital and everybody knew each other. I knew that some of the union reps, they were great, but I knew they were very friendly with the 2 of the sisters and so on, so I thought that's not necessarily going to be helpful. So I went to speak to the union regional rep, so I thought that would sort of give a degree of sort of outside influence. And initially, he was quite supportive. I told him what I'd done. I told him that there was going to be some investigations and we're going through that process. And he said, okay, well, you know, just keep me posted on how things go. So when myself and others started to have threats and intimidation made as well, to the fact that we'd spoken up throughout the whole process, a lot of us were threatened. As you can appreciate, it caused a lot of divide in the hospital and in the department, because a lot of people supported these 2 sisters because they were afraid of them. And a lot of people thought, well, nothing's going to change, so actually we don't want to go against them, we don't want to be seen to side against them. So it did create that divide. And obviously they did have their friends and genuine supporters as well. So it created a lot of animosity in the department. And that bubbled over into threats being made about our physical safety. So I was warned about walking to my car at night after a late shift, you know, watch your back when you walk across the car park because somebody's out to get you. People threatening that they knew where I lived. Really ridiculous but awful things. So it resulted in me having to have my dad or my husband come and meet me out of work. But then later as well, when the sisters were returning, there started to be threats around the fact that they were going to make it look as if I'd made a drug error. So friends were sort of trying to helpfully warn me, don't check drugs with so-and-so and so-and-so. But as I'm sure you can appreciate, in a busy A&E department, when you need to track controlled drugs quickly, you don't always have that luxury. So it was incredibly intimidating going into shift every day. So I did go back to the union rep at the point where we'd been told that they were going to return, and say to him, you know, what on earth's going on, because we haven't had any conclusion. And his tone was very different, very, very different. And he said, oh, yeah, and he obviously already knew. Oh, yeah, don't worry about it, don't worry about it. It's all been dealt with. You just don't need to know the detail, but it's all been dealt with. And I said, well, that's okay, but shouldn't we have a conclusion? I've not even had my transcript back from my meeting with HR and the investigating officer yet, or anything like that, and none of my colleagues have either. No, don't worry. They're coming back, they've had a slap on the wrist, so they're not going to do it again. And don't worry about the threats or anything like that. There's going to be some team building exercises, so it's all going to be fine. So I thought, well, I really don't think that's going to cut it, and they never happened anyway. So I just started to feel really, again, bemused and confused about the whole situation and the whole process. So it did get to the point for me where I did have to leave. I just thought, I can't do this. I can't keep going into work every day and being afraid for my own physical and professional safety. But also, I just can't see patients suffering and my colleagues suffering in the way that they were. So I did leave, and I went to work for another trust, and actually had a promotion, which was fortunate for me. But kept an eye on what was going on, because it was still my local hospital. I still cared very much about what was happening, and also kept in touch with colleagues, so I knew what the situation was, and it was no better, if not worse. So some time passed, and at the point of me leaving, we had the Healthcare Commission coming in, as was now the CQC. And they came in about 2 weeks after the two sisters were reinstated. Make of that what you will. And we were told that we weren't allowed to speak to them, but I did try. I spoke to an inspector as she came around A&E, and I gave her my name and said, look, I work here, and so on. But she never came back to me, and so I moved on. But so sometime after I'd left, that report came out, and it was the first time anything was identified at Mid-Staffs as being a problem. It was clearly not exhaustive, but it was enough for the first time to have identified that there were some key areas of significant concern, and it was enough to hit the press and the media. So I was driving home after a late shift, and the then Health Secretary, Alan Johnson, was on the radio, and he was being questioned about this, report that's just come out today. And he said, well, yes, it's very concerning, and we need to look into it more, and it's very, very worrying. But what concerned him more was the fact that no nurses or doctors were speaking up about the concerns in the hospital. So as you can imagine, there were a few expletives at the radio as I drove home. I was just incensed, and I had a day off the next day, so I managed somehow to get hold of Dr. Heather Wood, who led that investigation for the Healthcare Commission, told her everything. And she was really shocked because she knew nothing about it. And the fact that two sisters had just been reinstated literally 2 weeks before they came in. And she said we'd asked them for any significant investigations or suspensions or anything. And we saw a couple of token things, but very low level. She said nothing of this passed over us. So she said, if they've kept this from us, what else have they kept from us? So she said, she said, obviously my investigation's concluded, but I suspect there's going to need to be more. So have you got evidence of this? And of course I'd sort of kept copies of everything. So I sent her everything I'd got. And at the same time I started speaking to local MPs because I thought I just need to do more. And their response was really good. But at that point I did it under a sort of false name as well, because I was afraid. I was still working in the NHS and I was still really afraid. So we all now know obviously what happened, and I gave evidence at the initial independent inquiry, forensic inquiry, and then at the public inquiry. And of course by that point people knew who I was. They obviously had to. And then following on from that, also at an NMC fitness to practice hearing, in which the two nurses were actually struck off the register, which was really sad. And it shouldn't have had to come to that, but the evidence was so overwhelming against them. But at the same time they refused, even several years later, to acknowledge that they'd done anything. And that was the NMC's call. If they'd acknowledged and shown some insight into their behaviour to identify that they had learnt from it and changed, they wouldn't have necessarily been struck off. But it was the fact that they just, blatantly refused to accept anything that's what happened. But the other shocking factor for me was when I'd gone to the independent inquiry, I gave them all my evidence and more, obviously, as I'm giving it to you. So by the time I went back to the public inquiry, the QC who was questioning me said that they'd, in the interim, done some further investigation and found out some more. And would it surprise me to learn that they'd been told by somebody relatively senior in HR that a deal had been struck between the RCN rep and the chief exec. And the RCN rep had actually been representing the two nursing sisters at the same time as supposedly representing and supporting me. And he hadn't declared that conflict of interest. And then he had also made a deal with the chief exec to reinstate the two nurses without any further sanctions or anything against them before the Healthcare Commission came in. Otherwise, they would come back at the trust with a counter-complaint that the sisters themselves were being bullied. And that's the deal that was struck. So I was like, oh, yeah, that makes sense. I get it now. But was really horrified that those mechanisms and supports out there for us had let us down so dramatically in that whole situation and process. And that's really what then propelled me to do more, because I came away thinking, do you know what, mid-staffs isn't a one-off. It was a perfect storm, and there was a whole combination of things all there all at once that made it as bad as it was. But we know it wasn't a one-off, and we know that there are elements of that going on up and down the country in different wards, different units, different pockets of the NHS now. Therefore, there will be other nurses, doctors, healthcare, social care workers who are feeling like I did and feeling really vulnerable and thinking, well, I need to say something, but how do I? Or once I have said something and I'm hit with that brick wall, where do I go to next? What do I do? So that is really what then propelled me and led me to create the Ambassador for Cultural Change role at my existing trust. And the impact of that was huge. We developed it so that it would help change cultures around staff speaking up, but actually not just around speaking up, because it's a step before that. It's actually, if you get the culture right in the first place, staff will just be able to speak up. And it's about the link directly from the front line straight up to the executive and the executive level and board level, and that's who I report directly into. And the success of this role very, very quickly proved so much that we thought, well, we need to share this, and we did start to share it. In fact, Birmingham Children's Hospitals just here was one of the first to adopt the role in its entirety, and many, many others as well. And I started mentoring other people in the role, going up and down the country, helping other trusts establish the role and sit on interview panels and such. But then we thought, well, we need to do more, and there was lots of lobbying from lots of people up and down the country on the wider issues around whistleblowing in the NHS. So we had the Robert Francis Freedom Speak Up review in 2015, and I was asked by the Secretary of State to assist Robert Francis on that review, which I happily did. And he came up with several recommendations, but two of which were that every trust in the country would have a Freedom to Speak Up guardian based on the model of my role. And the second would be that we would have a national Freedom to Speak Up guardian to sort of oversee these roles and to create guidance and support and create a network to go across the country. So the national office was established in October 2016, so just 2 years ago. And there's been huge pace and projecting forward in that 2 years. It's been massive. We've still got a long way to go, but we now do have a guardian in every organisation. They vary slightly, and it worries me a little bit that there's not greater standardisation because we need greater consistency. But it's there and it's growing. We now have Freedom to Speak Up included in the CQC inspections under the well-led domain as well, which is really important to make sure that the inspectors come in and will want to speak to your Freedom to Speak Up guardian and should have that sort of access and transparency to do so. But for me, it's about sort of breaking down those barriers. So we know that the barriers still exist. We know that there's still massive problems with HR. And I'm not putting it all at HR's door because they have a very difficult role to play. And they do a really good job. But so much of my own experience and so much of what I hear now up and down the country is based around failures in HR. We need to get better at that. And we need to break down some of the hierarchy within organisations and the fact that staff don't feel able to speak up. They don't feel it's their place to. They don't feel that they're given permission to. Well, they absolutely are, and they must do. And even if they're wrong, even if as long as it's genuine, even if they're wrong, it's far better for somebody to speak up about something and have action taken and have it investigated, and then it proved to have not been quite accurate. But that's fine as long as it's established and as long as action is taken if it needs to be. We know as well that there are issues with the unions. Obviously, my own experience led into that. I now actually have to work with that rep, though, in my role now. He profusely apologised to me 5 years ago when I started creating the role, and my then chief executive helped sort of facilitate a meeting because obviously he understood the background. So he arranged for us to meet, and the union rep came in and literally bowed to me and took my hand and apologised profusely and said that he'd very much changed his practice and the way he thinks his role works since then. But he did apologise, and he said, "I threw you to the wolves." So he acknowledged it, and he apologised, and I'm a big girl, and I took it, and we worked closely together. In fact, I've been on the phone to him on the train on the way here because we're dealing with a case together. So, you know, it is important that we learn. It's not about hauling people out and shooting them at dawn. It's about saying, look, you know, we're all human. We will get things wrong. We are here to try and make things better for patients. Nothing in the NHS is going to be perfect, and it's always going to be changing. But we have to encourage the staff to speak up. We have to look after our workforce. We have to enable them to speak up freely, and we have to act when they do. Otherwise, patients and staff suffer. Thank you.
Thank you so much, Elaine, for, again, you know, a really, really heartfelt kind of, you know, raw experience that you highlighted about when it goes wrong, how badly it goes wrong, and how quickly things can deteriorate, and the personal consequences that has for individuals, and importantly for kind of patients and service users. So I'm really, really grateful for Elaine's time today, but we do have some time for some questions directly to Elaine, and then we've got a slight panel. So has anybody got a specific question for Elaine you want to discuss?
Hi there, thanks. Hi. Firstly, thank you. You're incredibly brave, and the bravery should be commended in speaking out about these sorts of issues. I was really caught by your comments about the current failings still within HR and the journey that needs to be done there. And I'm one of the few HR people in the room, so that really got my attention as well. What do you think the single biggest failings are, and do you think HR departments within NHS trusts know that these are current failings and the work that we've got to do around this?
Not necessarily. I think obviously every trust should have a Freedom Speak Up Guardian, and it's my drive that all Freedom Speak Up Guardians have a very close link to HR. I don't think they should sit within HR, again, to sort of keep that distance. But it's really important that you link in, you triangulate information, soft intelligence, because again, the important thing about the role really is that it's supposed to be preventative. We don't want it to wait until there's problems. We want it to be that kind of early intervention to try and put things right. And by working with HR, hopefully, and OD as well, massively, hopefully you can achieve that. So I would hope that they are aware, because they should be speaking to their Freedom Speak Up Guardian and all the other routes and methods that are out there, obviously. But I think some of it is just because they're just trying to get on with the day job. They're so busy, they're so pressured, as we all are. They've kind of got blinkers on, and they're just thinking of it in that kind of narrow tunnel vision almost. And sometimes we need to kind of put heads up, stop and go, hang on a minute, let's just look at the bigger picture. So much of HR is obviously kind of process-driven, policy-driven, and they're there for good reason, but they get in the way. They get in the way of the human element of it. And sometimes we just have to sort of heads up and go, actually, how would I feel if this was me? What would be a common sense kind of just reaction to it? And let's try and take it away from going down those very strict grievance kind of processes, because ultimately nobody wins. And let's try and get in there early before it gets to that point. But if it is going down that point, make sure that it's fair, make sure that it's as open and transparent as it can be. And I know that there are barriers to that for good reason, but so often there isn't a good reason, and it's just, well, you can't know that. We can't. And that just creates paranoia and builds up that sort of insecurity, and it just prevents people from speaking up in the first place. But there's lots of things I think HR workers can do to help break down some of those barriers. So I know HR are there to assist and advise the trust and the managers, but that then sets up a kind of us and them. So if you go and speak to your average member of staff, they don't trust HR, and they say, well, they're just there for the trust, they're just there for the trust. And they're not there for the trust, really. They're there to make sure there's fair process. And so for me, it's even about the position that HR people situate themselves. So literally when somebody is called to a meeting, firstly, you'd hope that they're prepared to have an HR person there. The amount of times I'm told by staff, but I just thought I was going to supervision with a manager, and I get there and there's somebody from HR and suddenly I'm being performance managed or something like that. And although if they do go to a meeting, they sort of walk into the room and there's the manager and the HR person and the desk, and then the person sort of sitting over here on their own, and it's quite intimidating. So it's even as simple as an HR person sitting sort of in the middle and physically representing that sort of balance. And I know it's silly, but it makes a big difference. So it's just little things like that, but it does go a long way.
Thank you. Lady.
Sorry, I'd just like to reply to that as a HR person as well. And I haven't grown up in the HR world, but I have grown up in the NHS. So I found myself here by default. And I kind of agree, really, that there's something about putting the heart into HR. And you may be there to serve the trust, but actually the trust is there to serve its patients.
Absolutely.
And that's absolutely what we should be doing. So, and looking at some of the encouraging work going on in other organisations like Masterclass around just culture and safety culture. We had a discussion with our team about revising policies around safety culture, and one of the HR business partners said, well, I've only ever been taught to write policies in a certain way, but it doesn't mean that they can't learn to do it differently and to make it work better. So I think it is work in process. I find it sad when people criticise HR because they are doing a big, a good job, but we need to get better at understanding how we best support the organisation, because by supporting the staff, you have to see, and that's the work I'm trying to do at the minute. So thank you.
No, thank you, and I absolutely agree. It is about changing hearts and minds, and it isn't about laying it at any one area's door, because it isn't. We've all got to work together, and there are some fantastic HR workers out there. So my very best friend is an HR, not in the NHS, but she is. So I know the good work they do as well.
Thank you. We do have a panel session now, so we've got an opportunity to ask further questions. And if I could ask Michelle to join us, Emma to join us, and is Lorna still here? No. And Helene, if you could join us on the front panel here. We've got time to ask some more questions of the panel, specifically related to the work we've talked today in relation to the workforce safeguards. I hope you agree that the kind of the day has helpfully or hopefully really kind of highlighted the kind of underpinning rationale and reasons for some of the new policy direction, also the kind of offer of support that goes into organisations, and also importantly, I think particularly with such powerful testimony this afternoon, I think really truly highlighting the kind of the nature and the scope of the challenges and how important they are to get these decisions right, the impact they have on individuals on the front line, but also the impact they have on leaders in kind of working in environments where these are quite challenging. So we've probably got about 10 minutes or so, 10 or 15 minutes so for kind of a panel discussion and debate. I'm really conscious that you have a long way to go, so we will kind of wrap up early, but I do hope that we can probably get you a little bit earlier at 3:30 before you can get to trains and things. So I'll open up the kind of discussion. Are there any immediate questions from colleagues in the audience?
I can't see. Is Helen still there?
She is, yes.
Hi, Helen. My name's Tina Lloyd from East Sussex Healthcare Trust. I'm just interested to know what your feeling is about the relationship between your a chief exec, that's not some of yours, and the director of HR in the HR department. I wonder, I think they get involved in some decision making and details, and whether that's appropriate.
It very much depends on the issue, I think. I don't think across the board it is appropriate, because that shouldn't be what they're there to do. But historically we've seen that things get missed and lost in translation, and sometimes things have to be escalated right up to the top. A, to get a sensible decision, B, to have ownership from an executive level, and I think C as well, so that it gives confidence and some faith to the staff involved that things are not getting lost in the middle. But ideally, it shouldn't have to go there, I don't think. But I think we're not to the place. I mean, that again is all about the cultural change drive. I think we need to get to a place where, I always say this, I'm talking myself out of a job, because I really don't think we need people like me, or shouldn't need people like me. Staff should be just speaking up as a matter of course. It should be responded to appropriately and effectively. That should then be learning across the whole of the organisation.
and the correct decisions and ownership should be taken from the board. But we saw at mid-staff that didn't happen. We see, as I said, in pockets and elements of other places that's not happening. So it very much depends on the situation, but I would hope that that's in the minority rather than the majority of cases.
Brilliant, thank you. Hello. Any further questions? We've lady there, and then yes.
Thank you. I think I'm the only doctor in the room. I'm a Deputy Medical Director at Dartford in Gravesham. You started the day, it's addressed to you, Professor. You started the day saying that it was about doctors and nurses, but we talked mainly about nursing staff. Yet, 46% of the GMC registered doctors were not trained in this country. 20% are EU nationals that are facing main issues, and I know there are nursing staff. What is NHSI going to do to help the process for all these doctors to remain in this country? And when the Commonwealth doctors thought that the doors would be open to them widely, and they are not. How are we going to square this circle that we don't have enough doctors? Because if you think that bank nurses or agency nurses cost a lot, when you look at the line of agency doctors, it is horrendous.
Yeah, no, great question. Thank you for that. So a couple of things. One, I think there's a natural tendency in these kind of conferences to focus in on kind of the professional aspects of kind of nursing, because that is something that has dominated the kind of NHS landscape when we talk about when we talk about workforce issues. But what I hope to try to do today, particularly in the early phases, is saying that actually these pressures and these issues exist across the entire workforce, and we need to think much more broadly about developing workforce safeguards at board level that don't just focus in on nursing, because actually that takes sight off scientists, midwives, AHPs and other people equally have an important impact in the quality and the clinical standards alongside IT professionals and a range of others. So today was about exposing it, but we've used a number of examples, particularly from the nursing field. What is NHSI doing? Well, it's a really important question, because you're absolutely right. I mean, the NHS has for a long time required the services of overseas staff and EEA staff working within the NHS. And there have been many public statements, both by NHS leaders, to say that actually we have to have a system that ensures that we're able to continue to access the support of these colleagues from across the globe in supporting the NHS. You'll have seen very recently that a number of organisations have already made a commitment in relation to supporting any residence fees, as well as also residency process. As NHSI, we're working currently directly with government, as and when information in relation to our detachment, as it were, from policy terms from the European Union, we are clear, then we'll be able to issue guidance that directly supports organisations. But I'm delighted that many organisations have already given a clear commitment to their staff, because that's absolutely what we should be sending the message for.
I know, but the issue is that we have relied too much on doctors from abroad. We have created 1,000 medical school places this year, but we were not going to reap the reward of that for many years to come. And the doctors don't want to come here anymore. So it is really a big issue.
It is.
That we're faced with on medical rota, A&E rota, every day.
Yeah, no, it's a very good point. So it is not unreasonable for one of the 10 largest economies in the world to have a safe and sustainable and self-sufficient model of healthcare worker development and training within our country. Everybody I've spoken to is senior leadership across the NHS and in the Department of Health and Social Security. Have absolutely health and social care. That takes me back, DHSS. I was just thinking, that shows my age a little bit. Have been very, very clear that that's a sustainable model is absolutely. However, in the short term, we are going to rely on our overseas colleagues in supporting what we do. So there are 3 strategies that we can effectively deploy in the short term. One is absolutely make sure that we are retaining the high quality overseas and EEA staff that are working within the NHS, and that has to be about organisations and the wider NHS supporting them in practice and making sure that they do feel valued. I understand that some colleagues don't as a result of that, and I think that's extremely sad and disappointing. We will require in the short term to ensure that we work directly with colleagues at the Home Office and the Foreign Commonwealth Office to ensure that actually we can adequately address some of our supply challenges by making life easier. But obviously that is government policy decision, so we await the government's decision in relation to things like visas. We've had some very encouraging changes to things like Cap 2 visas, etc. But actually we need to make some of those processes more streamlined to ensure that we're able to bring more colleagues in than are leaving. And importantly, we absolutely need to work on some of the, what in case of the long-term plan, there's an engagement process involved at the moment, particularly around workforce, and in there is a very clear indication in relation to the overseas requirement in terms of support. One suggestion colleagues from HEE are looking at in their global market team is how they can go abroad in both an ethical and a sustainable way to recruit colleagues. There's a number of examples where both nurses and doctors are coming to work in the NHS, but doing it in a structured way and doing it in a way that isn't necessarily denuding very, very critical healthcare workers from other parts of the world. So there are a number of things we need to do in the short term. I think the general view is absolutely our overseas staff are highly prized, highly valued, and my personal commitment is to work with DHSC, other arm's length bodies to ensure that we're able to make that transition as soon as possible, but culturally make sure that they feel valued, but importantly make sure their skills are retained within the NHS. Great, next question, lady at the front.
Thank you very much. Mark, just to say, first of all, fantastic programme today, and it's been well worth taking the time out to come to that, so thank you, and those speakers. I've got two questions, and I don't mean to hog the floor, but the first one is, in terms of ward manager, leaders, matron type roles, I find the issues are, in terms of raising concerns, that when staff come to them, they don't have the skills to manage that, and they're worried because they want to have the right answer and they want to be able to put it all right, and nurses tend to want to do that, don't they? So that's where I've been focusing quite a lot of my attention in developing the skills. I just didn't know whether Michelle or Helena had any views on what you've been doing to help with that. And the second point is around care hours per patient day and the publication of the data. I find it quite hard to find, and I'm just wondering what the public yet have said about that data, if it's of any value to them.
So question first to the panel. I think you could all probably have a view on kind of ward and department leadership, and your first question, then I'll answer the CHPPD one. Yeah, great. Michelle, do you want to start first, and then Emma and Helene?
Oh, from my perspective, Lynn, it really has been about engaging them and talking to them and finding out what they want to do. So I've developed a development programme, if you like, for our ward leaders, for band 7s and above. And what we're focusing on is not just the nurses, but on everybody at that level. So it's a multidisciplinary development. And part of that is the Freedom to Speak Up Guardian talking, is talking to them about how to have difficult conversations and all of those things that you would think, and we all did as a nurse, but actually the way that things have moved forward, we need to do much more of it. So we are doing much more sort of practical training. From my own perspective, it's about, I walk all the wards. I have a programme of walking all the wards, and I talk to people specifically about that. What's the biggest risk? What's your sickest patient? What are you worried about the most? What's on your risk register? And to get them into that conversation, and then when I meet with them, that's always at the top of the agenda. What data have you had this week? How can we share that? What are you really worried about? Tell me. And I can't always sort it out, but they do have that ear, if you like. And in honesty, all of our exec team have a complete open door policy, so they can go to any one of us for that. But and sometimes, and I say this in a positive way, sometimes it does mean as an executive, you do get the little bits that actually somebody else should be sorting out, but at least they're talking to somebody, and I'll take that until we've got it rolled out. So from my perspective, it is about professional training for them, and then about reminding them all the time about the importance of it, about their professional responsibility to do it, but giving them the time to be able to speak out and say, you know what, Michelle, this just isn't right. And if they do raise issues like that all the time, then I will say, I'm going to be down within 3 days to come onto your ward, talk to you about it, have a look what's going off, and let's see what we can do. We can't always sort it out, but I do make that commitment. So
brilliant, thank you. Emma.
Yeah. So So I would agree with a lot of that as well. When I was a director of nursing, I would meet with my band 7s separately to my matrons. And I also met with my band 2s and 5s as well. We used to look at the staff survey and see where different departments, when you get it down to your ward level detail, which different departments were having difficulties with their management or their leadership. And often when you sort of delve into it, as we all know, it's not, generally speaking, due to not wanting to be a good leader and supportive leader. Lots of our band 7s are escalated into their positions. They don't have the skills necessarily to do the job that we ask them to do. They just happen to be the best that there are and the ones that want to do more and further develop their career. So it was about also speaking to the band 7s as well as the 2s and 5s, openly, honestly, and discreetly often as well, about what they felt they needed. And there probably wasn't one ward sister in my experience that didn't know their shortfalls or didn't know what they found difficult to manage and deal with. And then we did exactly the same. We did a bespoke development programme for our ward sisters, and then our 6s who were going to be our ward sisters going forward to help to sort of skill them really to deal with those situations. But that's what we did.
Great, thank you. Helen.
I don't think I have much more actually, because I agree wholeheartedly with all of that. I think the point particularly around some who have been escalated into roles that perhaps they're not ready for and perhaps they don't really want. I've spoken to quite a few band 7 and above leaders who were sort of forced through management of change to take that role because they've reached their sort of threshold as a clinician and they're exceptional as a clinician, and then they were told, well, if you want to progress further or potentially be down-banded, you have to now lead the team. So they were kind of forced into it and then didn't necessarily have the wraparound support to be able to do that. So there is something about that. And I think there is something as well about the fact that I agree again that nobody goes to work to do a bad job. I really don't believe they do. And a lot of it is sometimes around people just not appreciating perhaps how they're coming across as a leader. So it's about giving them that early opportunity to sort of hold the mirror up, reflect, and then give them the support to perhaps change their manner, their behaviour, their responses to things. And then hopefully that can help improve cultures so that they can support their staff to raise concerns. But furthermore, as your point was, that if they don't necessarily have the tools or the permission to solve a problem, they need to feel enabled and empowered to raise that up further, rather than the push back down of, well, it's your team, you sort it out. Or, are you failing? Can't you sort it out? And that's how they feel, so they hold it and they don't do very much with it. So then the staff below are then coming to people like me, and I'm going to the ward manager and they're saying, I know, or I have tried to escalate it, but I'm not getting anything. And so again, that's where we come in to escalate it up further. But really, we want to not have that, and we want them to feel empowered and enabled to escalate appropriately, not be punished for doing so, and be supportive. And I think that again is a measure of whether you've got the culture right or not. So hopefully that is what's happening.
Yeah, thank you, Helen. So in regards to CHPD, so we've in the acute sector and specialist trust, we've been collecting it for about 18 months, 2 years now. It went live very recently in being publicly displayed. There was a clear commitment from the Secretary of State, as was then Jeremy Hunt, to move from planned and actual, which I think a lot of us understood as being, yes, that's great for a period in time, but it doesn't necessarily tell us any more detail than the plan that was implemented was correct. Doesn't tell you whether the plan was correct in its entirety. So Lord Carter and the team went away. They learned from the New South Wales model to bring that back. So Care Hours per Patient Day is, for those who don't know, is a composite measure of both registered nursing time and also healthcare support worker time. It's going to be an evolving measure, so we will be including allied health professionals to that number eventually, where they are substantively included within the establishment. And importantly, as a separate line of data, that the nursing associates, when they graduate and qualify, will be a separate line within the data. So we'll absolutely be able to have a very granular view and picture around the types of input hours that go into certain clinical environments itself. The caveats around that are that they are now published on My NHS and NHS Choices. So if you search for your individual organisation, you'll get the little banner come up with all of the different yes, no's, green, reds, etc. In there is CHPPD under one of the quality measures. You do have to choose it because it comes up with a default set of measures automatically. It does give you your aggregate CHPPD measure as an organisation, and I've stood on many public stages and say that measure, measuring one organisation against another, isn't what you should do, but what it does allow you is to click on that and drill down even further to look at the number of care hours input that goes into individual organisations, split out between registered nurses and healthcare support workers. So we've had to do a lot of work with NHS Digital. There is there's some patient and service user explanation sheets in relation to what CHPPD does. It is quite complex. I still have lots of conversations with clinicians up and down the country who get in a bit of a pickle in understanding what it can and can't do. It does not measure acuity. It's not a proxy for acuity. It just purely measures the input hours in that clinical environment. So it doesn't require you to change things like acuity tools, etc., because it won't derive that as an end result. It just does enable you to look on a daily and weekly basis the types of organisational model you have as to whether or not one specialty can be looked at compared to another to look for warranted and unwarranted variation. Mental Health and Community will be published in January, so those organisations will have the same public-facing nature. I personally haven't had any contacts, even though my name's on it, from service users, clients or the public in relation to the CHPPD measure, nor at this stage have I had any other interest from press or others in relation to do that. I have had a huge amount of interest from nursing colleagues up and down the country as to saying, why, what's this, what does it mean, why is mine different, why is this, and my board's asking me to do X, Y, and Z. So I'm more than happy to engage with anybody in relation to CHPPD, but there's some clear things it can do, there's some clear things that people think it can do that it can't, and there's some clear things that you shouldn't do with it as a result. And again, one of the key things is about educating and supporting people in terms of making those kind of right decisions. So, but at this stage, no, I haven't had a great deal of patient feedback. So we've currently got 5 minutes. As chair's prerogative, I have got 3 questions for the panel before I let them go. So I'm going to start with Helene at this time and say, Helene, could this happen again?
Yes. I think I alluded to that earlier in that, I think it would have to be quite exceptional again. And as I said, mid-staffs just did sort of tick all the boxes as a perfect storm. So whether we'll see quite the like of that again, I don't know. I hope not. And I think, 5 years on since the Francis report was published, I think there's been a huge amount of learning and willingness to learn and change and put things in place to try and prevent it happening again. But I'm still really saddened quite frequently, really, not just in my own organisation, I hasten to add, but across the NHS, because obviously I link in so closely with other guardians and other regulators and so on throughout the country, and still really concerned about a lot of the behaviours that go on in the NHS. And I think that's our greatest sticking point now, because I think the pressure's always going to be there. In fact, it's ever increasing, isn't it, in terms of funding cuts, in terms of demand. But I think the behaviour of some people in the NHS, and I hasten to add it's only some, it is the minority, absolutely, but for a health care environment, it shocks me how little people do seem to care, or at the very least they might be great with their patients, which is brilliant, but they're really bad at interacting and having decent relationships with their colleagues, and it really shocks me and confuses me, actually. I don't understand why. So I think there's a lot of work to be done around that, and I understand why a lot of it happens, because I said earlier, the pressure's on, people are just head down, just trying to get the job done under really difficult circumstances. But as I said before, my take-home message is, if we don't look after the staff, if we don't look after each other, we can't do this, and we won't have an NHS for another 70 years. So for me, it really is about sort of trying to look around and not expect perfection, and everybody has a bad day now and again, but just looking at how we behaved ourselves and try and respectfully call people out who are not behaving in an appropriate way, but crucially say, can I help? Do you need some support with something? And just try and help change that culture in that way. And I think if we do that, there's a lot less likelihood of it happening again.
Brilliant. Thank you. Emma, you've been quite close to the kind of safeguards document, the work we've kind of engaged a lot with the system. As a kind of director of nursing, how important is this document to get into boards for them to understand and how to kind of prevent some of these issues occurring?
Well, I think it's hugely critical that the boards take a joint sort of responsibility with making sure that these recommendations are implemented and support each other in doing so. I think that that's critical as well. I know it sort of says a lot, I guess. There's one doctor in the room and a room full of nursing colleagues, and it's fantastic to see some HR colleagues here as well. But this has always been sort of left to nursing directors to manage and hold the risk and not sleep at night, I think, fairly often, actually, when they're not only battling with sort of staff to try and support them through these staffing issues, but also trying to convince the board that this is the right way to do things. So I think it's absolutely critical. We've got stronger board engagement. I'm so thrilled that that's now going to happen, because we will be assessing that accordingly, and hopefully it will make some huge progress by also bringing on other staff groups like our medics, like our AHPs, and anyone really that delivers care to our patients. So I think it's very positive and hopefully very operational, able to be operationalised for you guys as well. So.
Brilliant, Emma, thank you. And the final question to Michelle, which is, you've talked a lot about your challenges today and been very open and candid in all of the things that I say. So I want to finish on a high note and say, what are you most proud of in all you've achieved with you and your team over the last year?
Oh, a lovely question. How long have you got? I've got a list, Mark, of what I'm proud of. I think what I'm most proud of is the resilience of the teams. So they are we do get constant scrutiny when you work in an organisation like ours. You get, as I said before, people turning up all the time. So the teams are so resilient. They come back day in, day out. They do have a moan, but actually they do what absolutely the best they can. And that shows. So we're not perfect in any way, but as I said earlier, our pressure ulcers are better than the national average. Our falls work is better than the national average. Because of the work that we've been doing. HSMR is coming down, so we know that we're doing the right thing for patients. So I think I would say that the teams are just, you know, the most resilient, and they keep turning up and doing a brilliant job. Can I just say one thing? Of course. I can't help myself, because I was talking to Mandy about this before, and one of the things that I wanted to do, and I leave you with this as something to think about. When I first started, I wanted to try and engage the nursing workforce a bit more than we had done. So the two things that you talk to nurses about if you want to engage them: car parking, always a winner. What a nightmare, leave that one alone. Uniforms. Uniforms! Let's have a conversation about uniforms.
Christmas off duty.
Christmas off duty is a good one, I'll leave that one alone as well. So I decided to go for uniforms, and Mandy knows this story. So we were looking around at uniforms, what we could do, what we can't do. We haven't got any money, so we've got to do this on the cheap, you know, so make sure that we can get them right. And one of our heads of nursing was in one of our hospitals, walking through the main reception. And she saw an agency nurse stood there, because there's a little cafe thing, stood at the cafe thing waiting to get a coffee or whatever it was. And she had a really nice grey uniform on with a pink stripe. I remember this distinctly, grey with a pink stripe, and thought, this is it. This is the one to go for. This is going to be blooming lovely, very professional. Went over to it and said, oh, you know, hello, my name is Linda, I'm the head of nursing here. And what agency do you work for? Because I really like your uniform. And she said, oh, I'm not an agency nurse. And she said, oh, really, where do you work? And she said, oh, I work on the 5th floor. And she said, well, why are you wearing that uniform then? She said, because I don't like the ones that you provide, so I've bought my own. This is at Pilgrim, and there is a uniform shop on the high street in Boston. Her and a couple of her colleagues had been down there, bought this beautiful uniform, and had been wearing it for 14 years. So when you want to engage people, talk about uniforms, you find out a whole host of stuff.
Fantastic. What a great way to finish, and thank you to the panel. If we could give a panel a round of applause, thank you. I believe Michelle does like after dinner speeches and stuff like that. She's been really funny today. So Just a very, very quick wrap up, and I'll get you guys out. I just want to say a massive thank you to everybody who's given their time today. Behind the scenes, there is a team who have done a phenomenal job in bringing all of this together. I'm immensely proud of my workforce team at NHSI, Tony and everybody. You've done a fantastic job in making this event work, getting the speakers together and getting everybody here. It's fantastic. So thank you very, very much for all of your support to do that. I hope it's been able to bring the kind of a policy document alive. There's something that we kind of send out and you go, oh great, another one. But I really wanted you to kind of get to the understanding that we've had engaging with this system, understanding the issues and challenges that are out there, and highlight how we want this document to work in practice, how we want to support you. So for the next year, we're going to be actively engaging with you to make sure that we can help embed this within your organisational governance models. Ask when you need help. Please come to us. We'll be able to find those who have helped solve problems that you're experiencing. So we can get this right. So in about 12 months' time, we'll be able to move to a national model of assurance in relation to safe and effective staffing across the NHS, which I think will be a phenomenal shift in position from where we currently are at the moment. That's about understanding risk. It's about understanding leadership, and I think you've heard from some phenomenal speakers today that really have kind of highlighted and articulated why it's so important to get right, because it's about those patients, those families, those service users and clients out there each and every day. We've got to get it right for that. I really do appreciate your time today. We do have an evaluation form. You often, at the end of the day, we go, oh, blimey, can I get it done and get out quite quickly? They are really, really important to us. We fundamentally change all of our programs of masterclasses as a result of the feedback. If we're not getting it right, please tell us. Absolutely, if we're getting it right, please let us know so we can make sure that our programs are exactly giving you what you need to be today. So if you could fill those in and either leave them on your chairs and leave them at the back before you go, that would be great. Once again, thank you very much to the AV team, and also importantly to Jury's Inn for hosting us today. I really do appreciate it, and I wish you a safe onward journey back home or back to work for some of you, and thank you very much for your time today. Brilliant. Well done.